Myself, Dr. Sanjay Deshpande, the convener of IISH and chairperson of Council of Sex Education and Parenthood International. I welcome you all on behalf of IMA Nagpur and IMA Initiative on Sexual Health. I welcome Dr. Reddy, chairperson emeritus, CSEPI, Council of Sex Education and Parenthood International, and president of Asia Oceania Federation of Sexology. I welcome Dr. Padmini Prasad, our dynamic honorary secretary of Council of Sex Education and Parenthood International. My very dear friend, big brother, Dr. Venkata Garu, Dr. G. Venkatramana from Hyderabad. He is vice chairperson of our Council of Sex Education and Parenthood International. And last but not the least, the immediate past president of IMA Nagpur, Dr. Kush Jhunjhunwala. I welcome all these speakers to this webinar. From the name itself, people are wondering what is the content of this webinar. Our webinar is love, sex and violence. Now these three topics, they are discussed at various different levels in different settings by different speakers. But they are very closely related to each other, considering the female sexuality and the male sexuality. All these three topics are important. And I really thank IMA Nagpur President Dr. Archana Kothari and Secretary Dr. Rajesh Savarbande, who took the initiative and have this courage to schedule a webinar on this. So thank you, IMA Nagpur. Now, as this is the IMA Nagpur is the host, I request our President Dr. Archana Kothari to give you her welcome address.
Good evening, all. Respected National President Dr. J.A. Jailal, Honorary Secretary General IMA Headquarters Dr. Jayesh Lele, all the dignitaries, those who are available today as speakers, Dr. Manjusha Giri, MMC Observer, Dr. Sanjay Deshpande, Chairperson of CACPI and Convener of IISH, and Dr. M. Balasubramaniam, Chairman of IMA National Committee of IMA Initiative on Sexual Health. A very warm welcome to you all from the city of Oranges, Nagpur. Today's topic, everybody wondered what we are going to discuss in this topic, love, sex and violence. A very catchy topic suggested by our own Dr. Sanjay Deshpande. And you all know that sex is very important, sexual life is very important, love is important. But what is the role of violence with these two? This is also very important, and that we are going to discuss today in this webinar. So, with this brief introduction, I will request Dr. Sanjay Deshpande again to continue with the proceedings, and will hand over the stage to him for further proceedings. Thank you. Thanks a lot. Dr. Sanjay Deshpande?
Yes, yes. Am I audible?
Yeah.
Yes, sir. Because I have a network problem, so what I am doing now, I'm just joining from my mobile.
Sir, you can mute any one of the devices and you can speak
Yes,
from
yes.
the other one.
Yeah. I have muted my laptop. Yeah. So friends, we say
So you need to decrease the volume of the other device as well, the one which you have muted.
I will leave from my laptop. That will be better.
No problem, sir.
Yes, yes. So friends, as rightly said by all of us, that ladies first is always the golden rule, being led by our dynamic president of IMA Nagpur. The first topic of our today's webinar will be presented by our Honorary Secretary of Council of Sex Education and Parenthood International, Dr. Padmini Prasad. Dr. Padmini Prasad is a very famous gynecologist and sexologist in the city of Bangalore. She is, I think, she is now elected as a president of Bangalore Obstetrics and Gynecological Society, and I think her installation ceremony is scheduled very recently.
11th, now next Sunday.
Yeah.
Sunday will be
our heartiest congratulations to you, Dr. Padmini, for being installed as
yes. I will
president
send
of
the
this
link.
prestigious organization.
Thank you very much.
So Dr. Padmini has a wide, she is very seasoned speaker on many topics on sex, counseling, education, and therapy. But she is master on female sexuality. She has presented all these topics on at various levels, national and international level. Just a week back, she had presented a topic on pregnancy and female sexuality at IISM level, International Sexual Medicine. So I request Dr. Padmini to start this webinar on love, sex, and violence by the most important topic, what is female sexuality? So I request Dr. Padmini to start her presentation.
Thank you very much, Dr. Sanjay, for that kind introduction. Good afternoon to you all. It really gives me a great pleasure to be with you all this afternoon or evening to talk on a very important subject. Sanjay was telling ladies first. No, we don't want first or last. We want equality. And that's all. That's the main thing, whether it is in the love or in the sex or whatever it is, we want equality. That's why we want to go side by side, not one behind the other or one leading the other. Okay, I will share my screen now. As you all know, sexual health and function are important determinants of quality of life. Few years ago, female sexuality was a non-entity. She was thought to be less sexual than man, and she is only a passive partner in sexual relationship. This has been proved to be wrong by the human experiments of Masters and Johnson, but it way back in 4th century itself, Vatsayana had given equal importance for female sexuality. With increasing education, employment, sexuality education, awareness, contraception, women's empowerment, there has been a sexual emancipation for the woman. Woman has changed. She has become a thinking and demanding individual. But man has been unable to keep pace with her progress. Few years ago, the man was bringing the wife for treatment, telling that she doesn't have interest, she doesn't cooperate, she doesn't enjoy sexual relationship. But now the reverse has come. The woman is bringing the man for treatment of male sexual dysfunction. She is complaining that he has weakness, his organ doesn't rise, he comes out very fast, I am not enjoying the sex. So really, so this is all leading to even the problems for the male, like performance anxiety, erectile dysfunction, premature ejaculation, or decreased libido in the man, in turn leading to disturbed interpersonal relationship, frustration, quarreling, anger, and even divorce. She has concerns and questions about sexuality during premarital period, pregnancy, postpartum, surgery, menopause, etc. So the doctors need to understand, recognize, diagnose, and treat sexual dysfunctions of the female. So every doctor should make it a point to include sexual history as part of overall history. So what you have to know about female sexual dysfunction. So sexual health is for procreation, recreation, and relation. The sexual response depends on a complex interplay of physical, psychological, and emotional factors between two persons. It is coordinated by the neurologic, vascular, and endocrine systems and influenced by family, society, and religious beliefs. So it is not a simple thing. Various factors have got an impact on sex and sexuality and sexual relationship. Any disturbance in these factors, whether it is a nerves, blood vessels, hormones, or physical, psychological factors, can all affect the sexual functioning. So what usually causes this female sexual dysfunction? There can be non-organic causes or organic causes. Even the social, cultural, psychological factors and organic causes like developmental factors, medical, surgical, medication, any of these things can disturb the sexual functioning. There can just an ignorance and inadequate knowledge itself can lead to various problems. The varieties of myths and misconceptions that we have today, so especially the virginity myth, the bleeding or the pain during first intercourse, that itself can lead to various sexual dysfunctions in the woman. So unreasonable and unrealistic expectations. Because these days the ladies come with, because they listen to so many stories, friends, and see in the media, so they will be having lot of unrealistic expectations. That is also responsible for sexual dysfunction. The day-to-day stresses, lack of time, exhaustion, lack of communication, the performance anxiety, and just a negative attitude towards sex. If there is a disturbed interpersonal relationship, and the psychological, psychiatric problems, social, cultural problems, the sexual dissonance, where the sexual expectations of partners are incompatible, the lack of privacy, hatred, bad experience, the sexual abuse, which you are talking about, sexual violence. So if she is a victim or the survivor of sexual abuse, that is also responsible for sexual dysfunction. So the other things like medication, lesbianism, the male sexual problems. The female sexual problems can lead to male sexual problems, or the male sexual problems them itself can lead to female sexual problems. And you all know the extramarital relationship can lead to definitely various dysfunctions. So why should we know about these dysfunctions? So what are these effects of sexual dysfunctions in the woman? Very low self-esteem, a sense of futility, frustration, psychological problems. So many times we see them getting treated with a psychiatrist for depression, anxiety, worry, unhappiness, and irritability. So many times doctor wouldn't know why she is having so much of anxiety or why she is having depression. So she will be under the treatment for depression. Only when you sit and listen to her and talk to her, you know that the deep-seated sexual problem, which is responsible for the anxiety. The marital disharmony, disturbed relationship, quarreling, arguments, all these things are the results of sexual dysfunction. And especially most of these gynecologists detect this sexual dysfunction when they come for treatment of infertility because of the social compulsion to have the child. So when they come for that 4 years, 5 years, 10 years married, and so many times they will not even have started sexual relationship out of ignorance or misconceptions or vaginismus or various dysfunctions. So ultimately, so many cases which go to family court for divorce are because of the sexual dysfunction itself. So the effect on male, as you all know, these are the thing. So when you how to know the sexual dysfunction, to know about the dysfunction, you should know about the normal function. What is sexual response cycle? Includes the desire, arousal, intromission, orgasm, and resolution. So according to these phases, so there is a linear model by Masters and Johnson's. So DSM-4 classification, which was there, now it is changed to DSM-5. So where some of these are combined and changes have been made. So according to this, if you take it, whether there is a problem with the desire, like desire phase disorders, whether there is a problem at the stage of arousal, or whether there is a problem at the time of intromission, like pain disorders, or whether there is an orgasmic dysfunction, whether she is enjoying sexual relationship, whether she is able to have the climax. So the female sexual dysfunction implies persistent or recurrent problems encountered in one or more of the stages of sexual response. It is not a dysfunction unless the woman is distressed about it or it negatively affects the relationship. So many couples are very happy with very infrequent intercourse and they are both of them are very loving, not bothered about this. So in that condition, there is no need to say that you are abnormal and you are not having proper relationship and we have to treat it. No, if they are happy, it is not a problem. So even with having daily regular intercourse, some couples are very unhappy that they are not enjoying sex. So it varies from couple to couple. So the incidence in the National Health Survey says that there is 43% of women are suffering from sexual dysfunction. It can be more because the women do not come out of this and doctors also do not think that it is an important issue to ask them, especially in the menopausal clinic and infertility clinic, the incidence can be very high. So some examples, if you want, you can just have a look at it. I will discuss about it at a later stage. Suma and Satish, they are married for 4 years. Satish has a complaint that Suma has no interest in sex. Even if the frequency is once in 3 to 4 weeks, she reluctantly participates in sexual intercourse. One of the most difficult thing in sexual dysfunction which can be treated is about the desire. There is no aphrodisiac till today which has been invented. So that is, it is very easy to say she is not interested, I have no interest. But there are so many causes for it. It is not a straightforward, simple thing. And you cannot just treat it by just giving one medicine for this. So another case, a Geeta, complains of burning during intercourse. She has no interest in sex. She often quarrels with her husband, Prakash. So each time she has, but she is not able to tell it or communicate it to the partner. She has got dyspareunia, but she is unable to communicate, tell that she is not enjoying because there is a lot of burning, irritation. And when you examine her, she has been suffering from vulvovaginitis. Another case where the wife was suffering from severe recurrent infection, genital infection. And when you check the husband, he had diabetes and recurrent balanopasthitis. So it is so very important to see the couple and see where exactly is the problem. Leela worries that she has not enjoyed sex from the time of her marriage. She does not feel it as pleasurable as it is described by her friends. So this nowadays, as I told you, there has been an unrealistic expectation. When I asked her, she told me, no, my friends are telling that they are enjoying like anything and I am not feeling anything what my friends describe. She is enjoying, she has been able to reach the climax and they are having regular intercourse, but just because somebody told that, it has to be like in a different way and you have to feel this, it is like a shock like thing. As soon as husband touches, you should have a shock. So many things which are told to them. So that can lead to unrealistic expectation. And as such, so many women are just happy being with a husband. Not even, they are not bothered whether they are getting orgasm or not, but being with a husband close to him and enjoying his relationship, that itself is pleasurable for many women. Vinod and Veena married for 5 years. They came for treatment of infertility. And when you really discussed with her, it was a case of non-consummated marriage and Veena complains of pain during intercourse. Each time she was giving that excuse, she has been having pain during intercourse and she was unable to cooperate with the husband, and only when you detected it after 5 years of their marriage, that was a case of vaginismus. Kamala has stopped menstruation since 4 years. Her husband has a complaint that she does not cooperate in sex. He is frustrated. They were having regular, normal sexual relationship. Once she attained menopause, so many of her friends had told her, so menopause is the end of sex life. There is no need to have and continue with the sexual relationship. Anyway, you have had children, grandchildren, you have enjoyed enough, and there is no need for. Psychologically, she was tuned to that. And even then, even otherwise also, she had some severe menstrual menopausal symptoms like hot flushes and tiredness, weakness, and also dyspareunia. So all these things have to be detected. Where is the problem? Why is the problem? And when both the couple, you sit with the couple and talk to them, you will understand what's the reason. So this is just when do you say that there is sexual desire disorder or hypoactive sexual desire disorder, a persistent or recurrent deficiency or absence of sexual desire or receptivity to sexual activity that causes marked distress or interpersonal difficulty. As per DSM-5 definition, it has to be that 75% of the time, and it has to be there at least for 6 months to call it as a distress. So the sexual arousal, inability to complete sexual activity with adequate lubrication that causes marked distress or interpersonal difficulty. It can be subjective arousal, or it can be genital arousal, or it can be both subjective as well as the genital. So the orgasmic disorder, the persistent or recurrent delay in or absence of orgasm after a normal excitement phase, causing marked distress or interpersonal difficulty. It can be a primary orgasmic disorder where she has never enjoyed it or have reached orgasm, or it can secondary orgasmic disorder can develop after a period of normal relationship. So the sexual pain disorders, which are now combined, dyspareunia and vaginismus in DSM-5. So recurrent or persistent genital pain associated with sexual intercourse that is not caused exclusively by lack of lubrication or by vaginismus and causes marked distress or interpersonal difficulty. The vaginismus, recurrent or persistent involuntary spasm of the musculature of the outer third of the vagina that interferes with sexual intercourse, causing marked distress or interpersonal difficulty. So in all these things, how do you take the history? So history is extremely important because most of the sexual dysfunctions can be diagnosed just by history. You can come to some conclusion where exactly is the problem, what's the problem. Taking the past history, personal history, the family history, family values, the attitude towards sexuality, and how they are brought up right from the childhood, and the medical history or if there is any illness, chronic disease or recent disease or recovery from a disease, or if they are on medication, the surgical history, whether there was any pelvic surgery, operation, or any other major surgery. The obstetric history, when did she deliver, what was the mode of delivery, whether there are any scars in the genitalia, episiotomy scars, the sexual history. After all this, a sexual history as per sexual response cycle, whether there is desire problem, arousal problem, at the time of penetration a problem, or reaching the orgasm or the experience, the satisfaction. And relationship history is extremely important. How the couple, you with each other, how they lead their life, how much of understanding they have, are they quarreling all the time? All these things will go a long way in detecting the cause of sexual dysfunction. So this is as per the sexual response cycle, whether there is pain, relationship satisfaction, or partner problem is also an important part of sexual history. So in such conditions, when you do the gynecological examination for the causes of sexual dysfunction, so this gynecological examination, you can make use of it both for the therapeutic purposes and diagnostic purposes. As you examine her, the way she behaves, the way she cooperates, or where exactly is the problem, you can call it as a body journey to teach her, remove the myths and misconceptions, make her understand about her own genitalia, and whether there even just a refusal to pelvic examination, and all the time giving excuses. I am not cleaned myself. I am not shaved. I am not feeling like having the examination. As soon as you put her on the table, she is arching her back and trying to get up, closing her thighs. That itself will indicate that she has been suffering from vaginismus. And after that, any place where there is a tenderness, there is a scar, infection, or deep inside, whether there is a problem at the outer area, or whether there is a mid-vaginal region or deep in the pelvis. So the monomanual examination, bimanual examination, speculum examination can give rise to some amount of these problems which can be there. So there are various opportunities where you can detect the sexual health problem. You can use it as sexual health screening prior to any gynecological surgery, because they have got lots of questions, but they are hesitant to ask the doctor. Directly you can answer that, and the concerns, whatever concerns they have before the surgery, at the time of menopause, antenatal visits, pregnancy and sexuality, the postpartum visits, when they can start intercourse, what can be the problem, how they have to go about it, the routine gynecological examination for any other reason. At the time you can ask, are you enjoying the sexual relationship, whether there is any pain, burning, and infertility is the best time to detect any problem and treat it. The management of chronic illnesses and depression, any psychiatric problem, psychological depression, whether there is any deep-seated sexual dysfunction can be. So depending on that, the investigations can be carried out. It can be routine investigations, detection of the diabetes or the hormone disturbance. All these things can be, or the pelvic scan, MRI, if there are any deep-seated pelvic problems, all these things can help. So when you come to the treatment aspect, depending on whether there is an organic cause or whether psychogenic factors are present, then organic causes you can treat depending on what exactly is the cause for female sexual dysfunction. Either it can be medical treatment or surgical treatment. And if there is non-organic causes or psychogenic factors, the sexual counseling, the sex therapy. There are various modalities of treatment. Main thing is prevention, the sexuality education, which is very important, which can remove most of the myths and misconceptions. You can use the Plicit model, sensate focus exercises, desensitization, behavior therapy, psychotherapy, hypnotherapy, narco-suggestion, all these things are suggested, but not all these things may be needed in all the cases. Most of the cases can be treated or guided with the simple things of sexuality education and removing myths and misconceptions. So if they know etiology, if there is an etiology, you treat that the cause for sexual dysfunction. Sometimes you may not find anything. A woman repeatedly coming for a backache, repeatedly coming for pain lower abdomen, repeatedly complaining of white discharge. So she wants to tell something so that she's in the hope of some doctor or the other might understand her problem. She keeps on coming to the doctor. But if you don't detect any of this problem, you can use basic treatment strategies. That includes the provide education for the woman, enhance stimulation and eliminate routine. You can teach her certain things. She can use some erotic materials, vibrators and things like that. Provide distraction technique. Encourage non-coital behaviors, which can slowly lead to the sensual massage and other exercises between the couple, which can ultimately lead to intercourse. Minimize dyspareunia, whatever, whether it is superficial, vaginal, or deep. So these are the usefulness of the Masters and Johnson Sensate focus exercises. It can reduce anxiety, improve sexual technique, reawake natural sensuality. It can eliminate goal-oriented approach, and it can eliminate spectatory. So this cognitive behavior therapy can also be utilized. The antecedents can lead to behavior leads to consequences, and consequence here is FST. So that can be treated through cognitive behavior therapy. You all know about it, CBT, what it is. So the thoughts on how you can change how you think or how you behave. So these are various modalities of treatment for different disorders. How much time I have? Another 3-4 slides I have. Can I know how much time I have?
You can finish those. No issues.
So if you come to the treatment of orgasmic disorder, if you come to know that she is not enjoying, not reaching the climax, so you can also teach her the directed masturbation. So let her understand her body. Let her understand what level of arousal she can reach the climax. The erotic fantasization. So sometimes they are scared to fantasize things. When you say that you can fantasize, you can imagine whatever that stimulates your mind. As far as the sexual feelings are concerned, oh, is it not wrong? Is it not crime? So many times the ladies ask, because it is very wrong on their part to think like that or masturbate like that. So these are all misconceptions which they have. They can use mechanical aids like vibrators, manual clitoral stimulation with the partner, sensate focus exercise. So partner can also be taught what exactly stimulates her, how he has to stimulate her body to get into the arousal so that she will be able to reach the orgasm. So these are some of the mechanical aids like vibrators, clitoral therapy device, orgasm enhancers they're called. So in case of the vaginismus, it is most difficult thing to treat. So it is very easy to say you can relax and you can use some jelly, use some local anesthetics and give her some sedation. All these things won't help her. It is not possible to treat her. There has to be systematic desensitization. There are 3 things. One is pain, one is phobia, and there is a spasm of the muscles. So all these things have to be taken care of using these vaginal trainers or dilators, some medicines, anti-anxiety drugs, Kegels exercises with dilators in situ, and Lubic gel for the dilatation. For her self-dilatation, if the finger is the best dilator which can be used. So when there is dyspareunia, see where exactly is the pain. Diagnose the stage. Pain at external genital stimulation, whether after the penile entry, whether there is mid-vaginal pain, whether there is deep vaginal stimulation is causing her pain, deep pelvic thrusting is causing her pain. So the physical examination and treatment of the cause, where exactly is the problem. So you can use some antibiotics if there are infections and use some lubricating jelly if she is feeling dry and some benzocaine gel. Estrogen gel, especially in cases of menopausal, postmenopausal women, and some of the painkillers. Never forget the partner. Whenever you are dealing with a case of female sexual dysfunction, so many times the man comes for treatment. Madam, I got erectile dysfunction or I got premature ejaculation. So the woman also comes and tells, I have no problem. You treat my husband. I am perfectly all right. But when you examine her, she will be suffering from vaginismus. So the most of the time, the man will go to some male doctor, urologist or surgeon, and repeatedly he will be swallowing sildenafil, but nothing will be happening because the problem is with the wife. So only when you see the couple together, you will understand where exactly is the partner. So that is why he will be thinking he is at fault. So that is a secondary erectile dysfunction where the man is suffering from. So a female sexual dysfunction can lead to male sexual dysfunction. So never forget the partner. Male sexuality is also equally important. If he is suffering from some problem, then that can also lead to female sexual dysfunction. Ensure that the partner is healthy. Ensure his financial, emotional, and social health. Women's sexual problems may be viewed as women not getting what they want. What women want? Women want consensual, mutually satisfying sex. Women want relationship. Women want self-love. They want time. Women want sexual health and liberation. Thank you very much for your patient hearing. Thank you.
Thank you, Dr. Padmini, for a wonderful talk. As I rightly said that you are the master in female sexuality. So, yeah.
Thanks for the compliment.
Thank you. So, ladies and gentlemen, all the speakers, I would like to recognize the presence of Dr. M. Balasubramaniam, our very dear friend, and the chairman of this IMA initiative on sexual health. Welcome, Dr. Bala.
Thank you, Dr. Sanjay.
Yes, I also would like to welcome Dr. Manjusha Giri, the Maharashtra Medical Council observer for this webinar. So, welcome, Dr. Manjusha.
Thank you, sir. Thank you so much.
Thank you. Dr. Balasubramaniam, I would like to request you, because you could not join because of technical reasons.
Definitely.
So please give your welcome address from IISH.
Thank you. Let it be even a vote of thanks also. It is a sincere thanks for the role Dr. Badmini has been playing in CSAP and various forums of Indian Medical Association, explaining the female aspects of sexuality and overcoming the various problems in female sexuality. And in fact, our initiative for sexual health has submitted a proposal to start a fellowship course in sexual medicine for the members of College of General Practitioners. We have submitted the proposal, and we take use of the platform to invite Dr. Badmini to be one of the resource persons, 6 resource persons, to join with other people, other faculties for this fellowship course in sexual medicine. And she will deal with all problems pertaining to female sexuality. We invite her to join, and we'll be thankful to her. And shortly we will have a webinar of all the faculty, 6 faculties. Sanjay Deshpande is there, Narayan Reddy is there, Dr. Sood from Delhi is there, Dr. Venkatramana from Hyderabad is there, myself from Chennai, and we have one more person from Karnataka also. So with these 6 people, we will start the fellowship course, and we will have some more invited faculties, and let us have a good curriculum for this fellowship, and let us produce, if not qualified, well-trained sexologists who can render the services to the public, who are now being exploited by the quacks and other people. So we thank you, madam. It's nice to hear your lecture on female sexuality problems. We thank you, and we thank the organizers, especially the Nagpur chapter of Indian Medical Associations. I had come to Nagpur when I was member of RNTCP, CGP, this program, for tuberculosis control program. I was there in the national working group in charge of Maharashtra, and I had visited Nagpur, Pune, and Mumbai. So thank you one and all. Thank you, Nagpur IMA and other people. Thank you.
Thank you, Dr. Bala. You are so loving and joyful person. You always cherish our friendship and relationship with you. Thank you, sir.
Thank you.
Our next speaker for today's webinar will be Dr. G. Venkatramana. Dr. Venkatramana is a trained sexologist, as well as he is a professor of dermatology at Hyderabad. Currently, he is a vice chairperson of Council of Sex Education and Parenthood International, and he is also president of Indian Andropause Society. And who can be the right person to talk about male sexuality than you, sir, being the president of Indian Andropause Society and very, very well associated with men's health. I think it is a proper decision of organizers to invite you for this most important topic, because we hear a lot of things about female sexuality, maybe because of many biological and social issues. But many times, though this is a male-dominated society, man is always forgotten. So to know it better from you, I invite Dr. Venkatramana to talk on male sexuality. Over to you, sir. Venkat, please unmute yourself. You are not unmuted.
Sir, you are not audible.
Yeah.
Now audible?
Yes, yes.
Okay, my friends. At the outset, let me thank IMA Nagpur branch and Sanjay Deshpande and our Dr. Balasubramanian for inviting me to speak on this topic of male sexuality. Some problem is there in rolling the slides.
You can just right click on the slide and click on next. So next time you won't get the same problem. Yes,
Yeah.
sir.
So now my topic given to me is male sexuality. So sexuality in general is a integral part of life, and it influences the personal identification, which is denied, repressed, or used effectively as a part of our lives. Sexuality is a process commencing at birth, ending only with the death. So right from birth to death, the sexuality covers entire lifespan, is a culturally defined and influences the family, peers, religion, economics, school, medicine, and science. In simple, the sexuality is nothing but sex is what to do, sexuality is whom we are. In simple, this is how the sexuality can be defined, and this sexuality is nothing but all about your body, your age, your sex, your gender, your activity, your orientation, your sexual drives, values, attitudes, and relationships. Once a child is born, based on the external genitalia, either a doctor or a nurse or parents can assign a gender to that boy, to that child. If external genitalia is like male genitalia, male gender is assigned. That is assigned sex, male gender. Then the parent starts rearing him as like a male. When he grows up, he himself identifies the gender assigned by at birth. Then he is very much satisfied with the gender. If he is not comfortable with that gender that is assigned by at birth by parents and doctors, there starts the internal struggle, gender identity problem. And the way he dresses, the way hairstyle, his makeup, his mannerisms, all will called gender expression. How he is expressing to the others, to society. And the physical attraction to whom he is getting attracted. He is attracted to woman, attracted to man, attracted to both. So that we call sexual orientation. So right from birth, assigned gender to his internal alignment with the gender identity, is the external expression in the form of gender expression, is sexual attraction towards which opposite sex or same sex or both. So all these things encompasses about the whole comprises male sexuality. If anybody is interested to know more about in detail, these are the best books which I have gone through, and that's why I'm putting here. Hyde's report on male sexuality, Christopher's male sexuality, and Jill Budgill's new male sexuality, and the oldest one, Kinsey's report on male sexual behavior of the male. So this male sexuality is nothing but how we see ourselves, how we think ourselves, how we love ourselves, how we feel about ourselves. So these are all the domains that deals with the male sexuality, right from the physical self to mental self, social self, emotional self, and ethical self. These are the 5 domains that deals with the male sexuality. The physical self is the way you look as a man. So once you are accepting your sexuality, then you will start doing exercise, going to gym, behaving like a man. Then the mental self, you are comfortable with this, then you will think as if you are a man. Otherwise starts the identity problem. Then next, the way you interact with other people, social self. Then another problem, emotional self. How you get emotionally connected with others. That's also very, very important. Then comes the ethical self. That means the way you value the relationship, ethical values. These are all the 5 dimensions that deals with the male sexuality. All these 5 dimensions again influenced by the various factors. If you go to spirituality, religion, feelings, value, beliefs, if you come to physical reproduction, birth control, pregnancy, sexual response, growth and development, all these factors will play a role. If you come to social sexuality, personal background, friendship, marriage, partnership, culture, legal aspects. So if you come to emotional area, learner behavior, education, attitudes, feelings, body image, like this, every domain is again influenced by the various factors. All these factors can be individual factors, family factors, local community school factors, and wider society factors. This lifetime sexuality, the male sexuality is nothing but starts from the birth and ends at the death. Lifetime sexuality is there are certain traditional stereotypes are there where society has focused on male as a assertive one, aggressive one, more interested towards sex, more into ready, always ready, and more emotional, less emotional, more towards physical attraction, more adventurous. So all these things are the stereotypes. But gone those days, now the things are changing. So the human's male sexuality, one has to study as a child, as an adolescent, as a youth, as a marriageable youth, after marriage, after 40, at the elder age, and after that as a single, as a divorced, as a widow or widower. So all these areas one has to study in order to understand the male sexual problems. So as a childhood, the sexual behavior of the male will be curiosity of the sex organs of the opposite sex, curiosity of masturbation, and questions regarding the pregnancy, childbirth related to sexual matters. Once becomes adolescent, he starts self-masturbating, self-experimentation, desire for the partner, love affairs, charting, surfing on the computers. Once becomes adults, problems of adjustment in sexual behavior, extramarital relationships, divorce, sexually transmitted diseases, unwanted pregnancies. Once become old age, lack of stimulation, degenerative changes will set in the body, and death of life partner, diseases related to sexual glands. So all these things one has to study, and all the problems encompasses about the male sexuality. And at the same time, I take this opportunity to again to congratulate IMA Nagpur branch and IMA initiative on sex, particularly Dr. Sanjay Deshpande, that he has taken up this in the month of April, because the April is observed as a International Sexual Assault Awareness Month. So he has taken up this issue, love, sex, and violence in the right time, in the right month, right place. That's why I once again congratulating him. Today, men are also harassed too. Gone those days that women are only the people are get harassed. Today, men are getting harassed. Now, 10% of the world population is suffering with men's harassment. As rightly said by the previous speaker, as per DSM-5, all the sexual problems has to persist for 6 months minimum and should be there at every moment of more than 75% times it should occur, and at the same time associated with personal distress. So these are all the parameters that are needed to label the person as having sexual problems. So all these problems will arise because of the misunderstanding or lack of information or bad feeling about sex or sex or fear of pregnancy, fear of losing control, problems in relationship, anger, jealousy, feelings of insecurity, unsuitable circumstances, alcohol, drugs, poor health, childhood negativity, and rearing up sex as a sinful thing, and adult discourage this natural expression, parent model of ambivalent attitudes to sexuality, ignorance, self-concept of sexuality, poor body image, all these things will contributing towards the male sexual problems. All the male sexual problems can be categorized into six areas, namely sexual concerns, that is myths and misconceptions. The second category is sexual adjustment problems. Third one is dysfunctions. Fourth one is sexual orientation issues. Fifth one is gender identity issues. Sixth one, paraphilias. So all the sexual problems that will fall into these six categories. How to evaluate these problems? When the patient comes to you and to me, how to evaluate? My dear friends, before going to this evaluation problem, I request all the healthcare providers, not only sexologists, all healthcare providers. Now, today, presently, we are working on the COVID pandemic environment. Please practice SMS. SMS stands for sanitization, mask, and social distancing. Please practice this to safeguard yourself and to safeguard the patients and to safeguard the society. So when any patient comes to us, to you, to me with sexual problems, then we will be evaluating based on the background theoretical knowledge of the few slides which we have discussed, that sexuality is a complex process coordinated by neurological, vascular, endocrine systems. So nervous system should be intact, blood supply should be intact, hormonal system, endocrine should be intact. At the same time, it incorporates family, societal, religious beliefs. So family values, societal values, religious values will have influence on the sexual response of that individual. At the same time, it also incorporates interpersonal relationships. So wife may be brought up in some area environment, husband may be brought up some environment. This boy was brought up in a different way, the girl was brought up different way, both getting married and now they are coming to one environment. Adjustment problems. So interpersonal problems will crop up here. So male sexuality is a complex phenomena shaped by personal, cultural, and social factors. So in order to have the sexual activity, happy, healthy sexual activity, one should have intact libido. Desire should be there. One should have favorable hormonal environment. Endocrine system should be intact. Adequate vascular supply, vascular system, blood supply should be good. Intact autonomic and somatic nerves. So nervous system should be good. Intact erectile tissue integrity also should be there. So all these things, when it is there in the right place, sexual activity will happen, couple will be happy. If the things go wrong, a breakdown in any one of these areas will lead to sexual dysfunctions. So all these sexual problems will lead to more relationship problems, poor general happiness, low self-esteem, low physical satisfaction, low emotional satisfaction, all this leading to diminished quality of life. That's why every healthcare provider, particularly sexologist who is dealing with this problem, has to evaluate keeping in view of these areas in order to raise the quality of life of that individual and that family and that unit, so that the national health will be maintained in a very positive way. If you look into the society, the prevalences of male sexual dysfunctions, lot of studies, Indian studies and foreign studies are there. All studies, depending upon the cohorts they have studied, various percentages are there, ranging from 10 to 52% of men at some point in their lives are experiencing sexual problems. One recent study in the Journal of American Medical Association was published in 1999 found that dysfunctions are more common around 31% of men at the age from 18 to 50 years. I am quoting few studies, Indian studies here, where these clearly showing that prevalence of male sexual problems are there. It's a reality. And old textbooks and lot of write-ups are there. The what you call the pain they suffered because of the sexual problems. Leo Tolstoy, the Russian writer, he writes that man survives earthquakes, experience the horrors of illness, and all the tortures of the soul. But the most tormenting tragedy of all time will be the tragedy of bedroom. So this clearly depicts how much the pain the male will undergo once he suffer with sexual dysfunctions. So also the female. Hell doesn't have such a fury as a woman whose man ejaculates before she. So this Paul Ameno is again the writer. She says the agony and the pain and the mental disturbances the female undergo when his man ejaculates early. So my dear friends, when any case comes to you with these problems, our approach should be there are certain prerequisites we have to maintain as a sexologist, as a healthcare provider. For dealing with sexual problem, it is absolute privacy and confidentiality should be maintained. Then only the patient will open up with us. It should be 1-to-1 or 2-to-1, absolute privacy and confidentiality. And your approach should be, or my approach should be, is in an empathetic way, more patient doctor relationship, positive approach should be there. Then only the patient will open up with their personal problems. For any medical problem, the history taking, clinical examination, laboratory investigation. So also for sexual problems, it starts with the history taking only, because history taking, if correctly taken, meticulously taken, that solves almost 90% of the problems. Only 10% needs a laboratory evidences to solve the puzzle. Otherwise, good history taking and physical examination, 90% of problems can be diagnosed and it can be addressed too. History taking, as I said, crucial first step in arriving the event of a diagnosed etiology of sexual dysfunctions. Large percentage of problems are diagnosed by meticulous history taking, but today it's not happening because physician time constraints. Because to take a good physical sexual history, it takes around 20 minutes to 30 minutes. So that much time the physician should be able to spare. If he is having 40 patients, 50 patients routine, then he cannot spare that much time. He cannot listen empathetically. So patient will feel that doctor is not interested, is not showing much interest to me. So that he will go to some other doctor, or he will lose confidence on the doctor. He won't follow the doctor's instructions. Another problem is the physician is discomfort with the topic. Unless the doctor develops interest towards sexuality, he cannot be a successful sexologist. He should become a non-judgmental attitude towards the subject. His personal image, personal value should not come into this patient's complaints and judgment. The third most important problem is lack of training in medical colleges. That's why our Balasubramaniam just now he declared that they are planning to start fellowship course so that all the healthcare providers can get trained, becomes a trained healthcare providers in this medical sexology. So these are all the three common reasons why this is not happening. As I told, prerequisites for sexology should be knowledgeable, open-minded, good verbal and non-verbal skills, non-judgmental and unbiased attitude, empathetic approach should be there. So if you are asking sexual history before like this in a OP, no patient will open up. The sexual history will be only mystery, not history. So one has to provide absolute privacy and confidentiality so that we can build up the rapport. And at the same time, we should not forget that the patient who is sitting opposite us is not the one here. It is the total unit, husband, wife, the relationship, and the family. All areas one has to evaluate so that we can get a comprehensive knowledge about the problem. So one to one or one to couple, one has to take the history meticulously in an empathetic way. So as I told, we always view as a couple problems. So you have to initiate. Who has to build the cat means we the healthcare provider has to initiate. Mr. XYZ, today's sex is happening everywhere here and there. Are you now active in relationship? If you are sexually active, whether it is with the wife or with the female or with the men or with the both, like that you have to initiate so that the patient will feel, yes, this doctor is interested in my sexual history. This doctor is really going to help me, so that the patient will start now telling his story. We always use open-ended questions. Give time for the patient to ventilate his problem. Don't use the closed-ended questions that will what you call uh, discourage the patient. So use always open-ended questions. So history taken, compliance, duration, and we will be going how long it is there, where, how it started, initiated, everything. And we will be asking whether it is primary or secondary or situational or global. So asking for a contributing factor, perpetuating factor, and we have to ask about the sexual preferences because that is very, very important. Whether it is heterosexual, homosexual, bisexual, pansexual, asexual, or queer nowadays. So these are all the areas one has to inquire in the history taking, past history. Then we have to inquire about diabetes, hypertension, all sexual surgeries, homosexual practices, interpersonal problems, medications, drugs, smoking, anxiety, depression, all these things one has to inquire about this. Then one has to inquire about the sexual dysfunctional area like arousal, how is the desire, how is the erection, how is the orgasm, how is the resolution, so that arousal disorders, erectile dysfunction disorders, ejaculatory disorders, or resolution disorders, all things one can get into a comprehensive idea. At the same time, prior negative experiences, premarital exposures, premarital friendship, failures, and trauma, sexual traumas, everything one has to elicit his stories, her stories, the sexual violence, all these things one has to inquire during the history taking. So all these things will have bearing on the present sexual problems. So cheating in the relationship, all these things one has to encounter, one has to what you call explore during the history taking. So child sexual abuse, partner issues like loss of trust, poor communication, lack of respect, lack of love. So this wife beating the husband, husband beating the wife, and both are beating each other. Children are now becoming orphans. So near it, so attitude, all these things will lead to, as I said, so near at so far syndrome, living in under one room like only guests, no more a sexless marriages. And at the same time, my friends, we have to inquire about food habits. Today, many sexual problems are arising because of couch potato syndrome, where we are just coming from the offices or coming down and sticking onto sofas, eating all junk foods and will make all saturated fatty foods, soft drinks, enriched with a lot of carbohydrates and fats, and this becoming more pahalwans, where we are producing more pahalwans, where they all endocrinal problems, vascular endothelial problems, resulting into sexual problems. We have to inquire about substance abuse, alcohol abuse, and cigarette smoking. This is the fundamental culprit in the male race. At the same time, we have to uncover how they are reared up, family values, and particular sleep patterns. The good sound sleep will have a very favorable hormonal environment. So people are having irregular sleep habits, working 15 days in the nights, 15 days in the day, and sleeping irregularly. All these things will affect their endocrinal system and indirectly affect the sexual response area. That's why you have to inquire about their sleep patterns And at the same time, I had to inquire about comorbid conditions, particularly obesity, diabetes, thyroid, cardiovascular, depressions, and medications. Today, my friends, all human beings across the globe, they are thinking that there is a pill for every ill. I repeat, there is a pill for every ill. But at the same time, all these pills are having negative effect on the sexual response. Right from the simple painkillers of aspirin, paracetamol, ibuprofen to highly biologicals. So a lot of drugs are having negative effect on the sexual response. See here, opiates, antihistamines, muscle relaxants, cancer drugs, Parkinsonism drugs, histamines, antidepressants, antidiuretics, antihypertensives, steroids, alcohol, this one antifungal drugs, estrogens. So all these things are having negative effect on the human sexual response. That's why we have to elicit drug history, not only allopathy, the patient is taking traditional drugs, OTC drugs. So all these things one has to inquire. Apart from that, certain diseases also one has to inquire. COPD, sleep apnea, HIV infection, chronic infections, all these things will have negative effect on the sexuality. At the same time, today in the present day lifestyle, we are facing a lot of endocrine disruptors. These are all the things that we are using in our day-to-day life, and these are all disrupting our endocrine system, particularly using of the phthalates. It's very, very negatively affecting our lives. Not only phthalates, pesticides, estrogens, xenoestrogens, soyas, so metals, pharmaceutical, industrial ingredients, solvents, all these, our sprays, body sprays. See how we are using pesticides here. All these we are consuming all the pesticide-ridden drugs. As I told you, the personal hygienic products do produce the increases the estrogen levels. This will affect our sexuality. At the same time, we have to inquire about the injuries to the pelvic area, injuries to the lumbosacral area. All these things will have a negative effect on the sexual life. And the injuries to the peritoneal pelvic area, operations on the retroperitoneal area, ileostomies, sympathectomies, colostomies, all these things one has to elicit. At the same time, elicit predisposing, precipitating, and perpetuating factors for this so that we can have a comprehensive sexual history taking. Then we'll be going to physical examination, where we'll be going to see the secondary sexual characteristics and a cardiovascular peripheral nerve pulse examination, neurological examination, respiratory, local genital, and rectal examination to see the genital tissue integrity. So then inquire about the neurological examination, cardiovascular examination, and will be organic like endocrines and the local genital tissue integrity in the form of genital malformation, infections, poor hygiene, and sexual trauma producing the Peyronie's disease, genital malignancies. All these things has to be physically elicited in the physical examination. Most of the times by this, the history taking physical examination will come to a conclusion. In a very few cases, particularly case it is under court of law and medical litigations and in medical dilemma, then only we'll be going for laboratory investigations. These are the list of laboratory investigations which we're doing. Special investigations like penile color Doppler study and penile biothissimetry and penile, this one, Regiscan. These are all the three special investigations which we'll be doing to know whether the person is suffering with sexual problem of psychogenic origin or organic origin. So after doing this, all these sexual problems can be psychogenic or organic in the form of psychogenically because of ignorance, mis and misconceptions, interpersonal conflicts, past negative encounters, child sexual abuse, or because of physical organic problems in the form of vascular disturbances, endothelial dysfunctions, neurological disturbances, hormonal disturbances, or infections, tissue integrity problems. So all these sexual problems, which I told you in the beginning, that will be into 6 categories, namely mis and misconceptions, adjustment problems, dysfunctions, orientation issues, identity issues, and paraphilias. Myths and misconceptions arise because of the wrong information, because of the parental strictness, not allowing the you explore the body, and the wrong notion from the wrong books, reading from wrong books, and peer pressure. All wrong notions will be percolated into the mind, producing lot of myths and misconceptions. Whether the organ size is correct or not, my beard is not coming, my height is not there, whether my chest is like this. So many problems the patients will come. All these things can be cleared by sex education and counseling, myths and misconceptions. Then comes the adjustment problems. Here, more marital therapy and counseling will work out here. Adjustment today, my friends, both are working together, both are coming equally exhausted, coming here, and both are losing their patience, and both are losing the adjustment capabilities. Both are becoming egoistic, and that is coming in the way of their sexual life. A lot of adjustment problems. In 1947, when the independence came, the divorce rate of the country was less than 1%. Today, the divorce rate is up to 20 to 25% from metros, 18 to 20% in cities. So you can imagine how much increase in diversity is there. Asking a couple are claiming for divorce. So that shows losing the patience in adjusting the relationship. So adjustment problems are increasing. Sexual dysfunctions, again because of the desire dysfunction, erectile dysfunction, ejaculatory dysfunction, resolution dysfunction, producing priapism. Sexual orientation issues like attracted to the male, attracted to the female, attracted to both, or attracted to all. That is asexual, pansexual, homosexual. Then identity disorder, the identity given by the at the birth, he is not comfortable with that. His mind is not accepting that. Identity disorders, that is intersex, LGBTQ, all these issues are will be addressed here in the sexual problems. Then comes the paraphilias. So this unnatural sexual this paraphilias, some are very minimal, not traumatizing, some are very harsh, traumatizing relationship and litigant and medically and legally punishable. The IPC 377 deals with this, except homosexuality is cleared by Supreme Court now. Rest of the problems again still under the ambit of the IPC 377. Plenty of paraphilias is there. One here, now I am focusing the scoptophilia, that is peeping toms. So all these sexual problems, which I have told you, can be tackled by counseling and sex education, clearing the myths and misconceptions, and individual couple counseling, behavioral therapy, treatment of genital infections, and hormone replacement therapies in case of andropause, drugs orally and locally, like PDFI inhibitors, vacuum device treatments, penile vascular surgeries, and ultimately penile implant surgery. Cognitive behavioral therapy, rational emotive therapy, aversion therapies, and age-old sensitive focus and squeeze techniques. All these things are case-based, individual based to have to choose which therapy suits that particular couple or that particular patient who have to administer that. My friends, to sum up, the male sexual problems can be easily tackled provided the healthcare provider is empathetic, non-judgmental, more patient-friendly attitude is there. Their sexual problems can be easily tackled, and we can make the couple to become more happy. And at the same time, if the doctor-patient relationship is more in a positive way, that will enhance the couple relationship. A double boon will come, and we will be saving more sexual problems will be reduced in the community, and divorce rate will come automatically in the community. With this, I am closing my talk, and I thank you all for your patient listening. Over to Sanjay.
Thank you, Dr. Venkat, for a very important talk on male sexuality. And as rightly said by you, the take-home message is understand the man, understand his feelings, his surroundings, his compulsions, his fears, his anxieties. Don't treat a man like a performer, but treat a man as a human being. That's most important. So thank you very much, Venkat. In your unique style, you are always the best. So thank you very much. So friends, now we have now covered about the sex part of today's webinar. Between sex and violence is love, which may prevent the violence in a man and woman relationship. And to talk on this topic, we have none other than Dr. D. Narayan Reddy from Chennai. Dr. Reddy is a mentor of nearly all of us. He imbibed the good habits and values in us as a sexologist or sex educator, counselor, and therapist. He has a vast experience of treating the patients, but that is a small part of his career and personality as a sexologist. I can tell you, there is an American Association of Sex Educator, Counselor, and Therapist. And Dr. Reddy is not the only certified sex therapist, but he is the certified supervisor of sex therapist. So he can certify a person who works with him under his supervision as a trained sex therapist in United States also. He's also associated with IMA CGP and is a certified, he's a course coordinator and faculty for IMA CGP course on sexual medicine, as told by Dr. Balasubramaniam in his address. He has official position as the president of Asia Oceania Federation of Sexology. He is chairman emeritus of our organization, Council of Sex Education and Parenthood International, and I have proud privilege to be associated with him as an honorary secretary when he was chairman of this organization for 6 years. He is a patron of Indian Andropause Society and is associate editor of Journal of Sexual and Relationship Therapy. He has many awards to his credit. One of the few most prestigious, I will name, Distinguished Fellow Award from American University, Lifetime Achievement Gold Medal Award from World Association of Sexual Health in 2017, and I have proud privilege to be present at that moment with you, sir, at Sydney. Then Lifetime Achievement Award by Tamil Nadu Dr. MGR Medical University, and Lifetime Achievement Award by our own organization, Council of Sex Education and Parenthood International. His most prestigious award is the respect and love from all of us. So I now request you, sir, to talk on love and hormone. I request
All the more, he is the, I can proudly say, he is the doyen of Indian sexology.
Yes, very true. So, Dr. Reddy, over to you, sir.
For your kind words of introduction. Now, friends, you have listened to two wonderful lectures, one about female sexuality by Dr. Padin Prasad, the other one about male sexuality by Dr. Venkatramana. So now I step into the realm of LOVE, love, the four-letter word. May I have the first slide, please?
Sure, sir. Just a moment.
Next slide. Yeah. I've been asked to speak on love and how the body drives the emotion called love. That's why we titled it Sex and Love and Hormones. Next slide, please. What exactly is love? I'm sure each person will define it in his or her own way, from their own perspective. Next slide, please. To tell you the truth, there is no comprehensive definition. extremely difficult to define. All of us understand what love is, but we cannot define it. Next slide, please. Now, in a lighter vein, here is a WhatsApp cartoon. A young modern girl says to her dad, "Dad, I am in love with a boy who is far away from me. I am in India and he lives in UK. We met on a dating website, became friends on Facebook, had long chats on WhatsApp, proposed to each other on Skype, and now we have had 2 months of relationship through Viber. I need your blessings and good wishes, Daddy." Now let us see what the modern daddy says. Next click, please. The modern daddy says, "Wow, really? Then get married on Twitter, have fun online, buy your kids on eBay, send them through Gmail, and if you're fed up with your husband, sell him through OLX." This is how people today behave and talk about love. Next slide, please. Initially, novelists and playwrights are discussing love. Since past 4 decades, scientists and researchers step in. If you take any movie, be it Bollywood, Hollywood, Collywood, or Tollywood, whatever it is, the movies have to revolve around the concept of love. Then you have added elements like violence, sex, and other tragedies. But the core theme is love. The theory of biological basis of love has been explored by such biological sciences as evolutionary psychology, evolutionary biology, anthropology, and other neural sciences. The point, my dear friends, we are struggling and stagnating still at medicine and surgery. We are not evolved in looking at all these evolutionary sciences, and that's very important. In my opinion, every good sexologist must be also knowledgeable about anthropology and sociology. Next slide, please. Now, Leo Buscaglia, a very famous psychologist from New York, he defined sex as love as follows. Love is an emotion. He doesn't stop with that. He also says it is also a response to an emotion. So it is not a one-way traffic, it's a two-way traffic. That is why love is a learned phenomenon. How one learns love will be somewhat determined by culture in which one grows. Scientists, especially pediatricians, have studied if the mother is not paying attention to the child who is crying to draw attention to the mother, slowly the child loses interest in the mother. Similarly, the child is a deaf mute and does not respond to mother's provokings or proddings. The mother starts losing interest in that child. It is not we are saying, it's like scientists like pediatricians are saying that. That's why it is said a learned phenomenon. Next slide, please. Now, there's a word called limerence. What exactly is this? The experience of having fallen in love and being irrationally and fixatedly love smitten, irrespective of the degree to which one's love is requited or unrequited. Whether other partner is reciprocating or not, we still have a hang up about this particular lover. Next slide, please. What exactly is the function of love? Love, in its various forms, acts as a facilitator of interpersonal relationships. Next slide, please. There are many people who try to propose theories about love. You have Sternberg, you have Pillay, you have Shaver, Hazen and Bradshaw, and Dutton and Aaron. Triangular theory of love love as addiction. They say love is actually an addiction. Somebody said love is a deep attachment, and somebody said love with the same feeling is when you travel in a roller coaster or in a merry-go-round. It produces arousal. So, the arousal of any emotion is called love. Next slide, please. Now, how do you classify love? There are two classifications. One, companionate love. Second is romantic love. Next slide. What exactly is companionate love? It's an intimate, non-passionate type of love, which is stronger than friendship. Why? Because of the long-term commitment. In companionate love, there's a long-term commitment. In friendship, there may not be any long-term commitment. Don't believe cinema writers and script writers that love and friendship are the most important things in life. No, sir. This type of companionate love is observed in long-term marriages where passion is no longer present, but where a deep affection and commitment remain. The love ideally shared between family members is a form of companionate love. Here, the element of passion doesn't exist. It's the deep bond that exists, a long-term commitment. That's companionate love. Next slide, please. Now, Sternberg theory, triangle theory of love. And the specific reason why I'm showing you this particular theory. According to Sternberg, the theory is like a triangular. And on the top, you have intimacy. At one of the angles, you have passion. The other angle of the triangle contains decision and commitment. I will tell you why this is important for us to understand. Next slide, please. Romantic love derives from a combination of intimate and passionate components of love. Can you go back to the previous slide? Yes. You see, intimacy and passion, when they combine, you have romantic love. Where you have intimacy and decision or commitment, you have companionate love. Next slide. Romantic lovers are not only drawn physically to each other, but are also bonded emotionally. But they don't have sustaining commitment. Romantic love need not have a sustaining commitment. Next slide, please. Now, scientist Lee, he has classified or typology, described the typology of romantic love. Eros. Eros is based on physical attraction. When people are physically attracted, now how we are attracted to a cinema heroine, we may consider it to be a love. That is called eros. Ludus, a playful, casual variety. What is shown in our movies? First 5 reels of a movie, there is always a clash between the hero and the heroine. The next 5 reels, they've developed love. That is called ludus. Storge, based on warmth and affection. Mania, a stormy and turbulent variety. If I can't get this girl, nobody else should get this girl. Either I kill the girl or I kill the other lover. Films like Bazigar, Dar in Hindi, and Wali in Tamil, they all fall into this category. Pragma, a level-headed and practical view. Even though Lee has typed this as a type of romantic love, I personally do not consider to be a type of romantic love because when you think about practicality, where the question of love is more of a negotiation rather than of love. Then finally, agape, the traditional Christian view variety. Lee, being a Christian, used the word Christian. But in reality, this will be shown in most Indian movies where the mother is all forgiving, the wife is all forgiving. According to Lee, he has not come across a single case of agape, whereas he came across other 5 types of romantic love. Next slide, please. Then what triggers love? What exactly prompts us to love the other person? Next slide. Now, Martus and Johnson have described the romantic love cycle. First, a person goes into a state of love readiness, is ready for love. Then he falls in love. Then he is in love, being loved. Next click, please. When you are in love, then you go into a stage of transition in love, where you unmask reality, you develop boredom or impatience, frustration or hurt, testing. When this transition goes through and you successfully manage that, you may go into stage of companionate love. Again, from being in love, you can go to companionate love. Next click, please. Now, some people from transitional love, they develop conflict in love, and if they have truth, they go back to conflict. Next click, please. After truth, they may go back to love in transition. Next click, please. And the conflict resolved. Next click, please. The conflict resolved, you go back into being in love. If the conflict is not resolved, next click, please. You fall out of love, then you be out of love. If you are out of love, then the cycle starts next time you meet another girl or a lover, again go back into love readiness, etc., etc. So Masters and Johnson describe how the romantic life cycle works. Next slide, please. Now, what exactly is love readiness? There are certain elements which will tell us that we're ready for love. Seeking love as desirable or rewarding. That means we must think positively about love. Having a longing for interpersonal intimacy and companionship. We should crave for companionship. Then we should be sexually frustrated. And we should also be optimistic, thinking that we'll be loved by our lover. These are all the elements of love readiness. Next slide. Now the question comes, is it all in the mind, or next click, or is there any biological component? Scientists have studied and they now claim that there's a biological component as well for this emotion in the mind called love. Next slide, please. Here is a schematic representation about the chemistry of love, how these hormones, serotonin, norepinephrine, dopamine, they all help a person to fall in some type of love. Next slide, please. Helen Fisher of Rutgers University, USA. She is a person who studied love most extensively in the world. She has published more than 350 papers on the single subject of love. That is why whenever people talk about love, they have to quote her, they have to use a reference. She has proposed 3 stages of love, namely lust, attraction, and attachment. And she says that each stage might be driven by different hormones and chemicals. Next slide, please. Stage 1 is called lust. This is the first stage of love and driven by the sex hormone, namely testosterone and estrogen in both men and women. I hope that all of you realize and know that both males and female, they carry both the hormones, testosterone and estrogen. Only thing, in the male, the levels of testosterone is much more than the levels of estrogen, and the woman, the levels of estrogen far outweigh that of testosterone. So the stage of lust is driven by these two hormones. Lust is also known as sex drive or libido. So don't mistake thinking that lust is something bad. People unnecessarily use a pejorative meaning, giving it a negative connotation. Say lust is bad, is lusting. No, sir. Lust is a good thing, the first stage of falling in love. It is required for human life and human emotions. Lust is also described as borogodo. Next slide, please. The second stage of love is attraction. This is an early stage of intense romantic love. This is the amazing time when you are truly love struck and can think of little else. Scientists think that three main hormones or neurotransmitters are involved in this stage, namely adrenaline, dopamine, and serotonin. I would strongly recommend that all of you read this wonderful book called Why We Love, The Nature and Chemistry of Romantic Love by Helen Fisher. Next slide, please. Adrenaline. The initial stages of falling for someone activates our stress response. It increases because the stress response is triggered. It increases our blood levels of adrenaline and cortisol. Now, this produces a charming effect that when we unexpectedly bump into our new love, we start to sweat, heart races, and our mouth goes dry. Those of you who remember yesteryear Hollywood heroine, those of you can remember, Sophia Loren, she herself sang this song in one movie. When she has fallen in love with a dentist, she sings, "Doctor, my heart goes boom, boody, boom, boody, boom." That means what? It races fast, body starts to sweat, and mouth goes dry. Next slide, please. Dopamine. Helen Fisher asked a newly love-struck couple to have their brains examined and discovered that they have high levels of the neurotransmitter dopamine. This chemical stimulates desire and reward. Because when you desire something, a reward is available, a desire again increases. It's work with what you call that feedback mechanism, biofeedback mechanism. Dopamine is a biofeedback neurotransmitter which helps us to gain pleasure. This rush of dopamine has the same effect on the brain as one takes cocaine. That's why people who use cocaine, they get addicted to it. Again, the same thing happens to lovers. That's why we say we fall in love. We get addicted to love. Fisher suggests couples often show the signs of surging dopamine, increased energy, less need for sleep or food, focused attention, exquisite delight in smallest details, of this novel relationship. You see any of the romantic movies, the director portrays this through a song. If you see the old movie Blackmail, Pal Pal Dil Ke Saath, you can understand this. Next slide. Serotonin. Finally, serotonin, one of love's most important chemicals. That may explain why, when you are falling in love, your new lover keeps popping into your thoughts. Next slide, please. The final stage of love is called attachment. It's a state of deep feelings of union with a long-term partner. Attachment is a bond that keeps couples together long enough for them to have and raise children. If they are not in attachment for long, they cannot have children, they cannot raise children. Most of families will stay in a long-term relationship. Scientists feel that there are two major hormones involved in this stage of attachment, namely oxytocin and vasopressin. Next slide. Oxytocin, also known as the cuddle hormone. Oxytocin is a very powerful hormone released by men and women during orgasm. In our college days, we were taught the use of oxytocin only to use, yes, you guessed right, to induce a labor. We used to have pitocin drip, but today we realize that when the genital organs contract and relax, that is due to the hormone oxytocin. So the more the oxytocin, more powerful the orgasm. It probably deepens the feeling of attachment and makes couple feel much closer to one another after they have had sex. That's why the theory is that the more sex a couple has, the deeper their bond becomes. Friends, please understand the importance of sex. Don't brush aside sex. Don't think that sex is unimportant, it's unnecessary luxury. Sex is very important because it bonds people together. It's very important for a relationship. We must understand this. Next slide. Diana Witt, assistant professor of psychology at that time at Binghamton University, New York, she has showed that if you block the natural release of the hormone oxytocin in sheep and rats, they reject their own young ones. There is no attachment because we have blocked oxytocin. Conversely, when we inject also oxytocin into female rats who never had sex, it causes them to fawn over other females' young ones, nuzzling the pups and protecting them as if they were own. That's why it is important for us to understand the effect of oxytocin. Next slide, please. Finally, vasopressin. Vasopressin is another important hormone in the long-term commitment stage and is released after sex. Vasopressin, as you know, is also called antidiuretic hormone. This antidiuretic hormone works with our kidneys to control thirst, but its potential role in long-term relationship are discovered when scientists looked at the fairy wall. Here is a picture of fairy wall. You can see they almost resemble mice. Fairy walls indulge in far more sex than is strictly necessary for the purpose of reproduction. They also form fairly stable pair bonds like humans. When male fairy walls were given a drug that suppressed the effect of vasopressin, their bond with the partner deteriorates and they lost their devotion and failed to protect their partner from new suitors. What does it show? That vasopressin has got a bonding effect and it will result in a long-term commitment. This stage of attachment. The final slide, friends. Now you understand why it is important for us to know the link between emotions and hormones. It is not just only in the mind. The body also works hard by having these neurotransmitters called hormones. Please understand, hormones also are a variety of neurotransmitters. The only difference is hormones act in remote areas without any ducts or channels, whereas neurotransmitters works very close proximity through neuronal channels. That's the difference between hormones and neurotransmitters. You must understand, Venkat has clearly told us in his presentation, he spoke about endocrine disruptors. Today, as they showed in the pictures, we are flooded with neurotransmitters. He mentioned phthalate, and we drink water from water bottles. Plastic in its basic form is not hard. To make plastic hard, they have to mix it with phthalate. So only a bottle can form, only then bottles can form. So every time when we drink a Bisleri, Aquafina, or whatever water we are using, remember phthalate, the endocrine disruptor. All perfumes, deodorants, all of them, they are all endocrine disruptor contained. Then today, through Swiggy and Zomato, we order food. How do we bring our gravy or kurmas in aluminum foils? The aluminum foils are basically layered with chemicals to prevent oil from leaking, liquid from leaking. That layer contains endocrine disruptors. And your Teflon coated non-stick dosa pan, other pan, they all contain endocrine disruptors. So today, if you find somebody says that their emotions or love is lost, please think in terms of endocrine disruptors only when you realize that they are linked to hormones. That's why it's very important. So the question will come, Dr. Reddy, you said about water bottles, but today, can we live without plastic? No, sir. I can emphasize. Initially, we were all trying to avoid using plastics, like using a paper bags, paper cups, etc. Then came COVID. We have to use disposable things. Only plastic can be used for disposable things. We are back to square one. This is the price we pay for modern day lifestyle. So friends, you understand the link between emotions called love, hormones, and endocrine disruptors. And once you understand that, you will understand everything else. Thank you very much.
Thank you, Dr. Reddy, for your this, I must say, mesmerizing presentation about the love. Many new things we knew about love, and many reasons we knew about why we love. So that was an excellent presentation, sir. Thank you very much. Without wasting much more time, I will start my own presentation now. So I have chosen actually to talk on love and violence. But basically, Dr. Reddy has described love in such a beautiful way that I will skip that love part, and I will be restricting myself on the violence part, because it will be most of the repetition. No, when I was preparing about this topic, I thought why this is. why love and violence, they exist in the society. Because we know that if hormones only are playing the role, then everybody would have been very loving. But that's not the reality. So I thought, are they love and violence the extreme two poles of the same axis? Because sometimes we see that we see in the reports, in newspapers, on television, a person was having in a very good loving relationship with someone, and suddenly he or she kills that person whom she or he was loving very deeply, passionately, compassionately, whatever it may be. So are they really two poles of the same axis? Why people in intimate relationship commit violence? Why men beat their wives? Why boys they tease girls? Is passionate love which leads to violence if it is not reciprocated? Like that, whatever we see in movies, Inder or Bazigar, or there was one more movie, I don't recollect the name, but it was featuring Shah Rukh Khan and Madhuri Dixit again. Why males are more violent than females? Dr. Reddy told that the number of hormones, they may be more in females than in males, which were causing the love in their minds. But is it only a biological phenomenon, or is there any other dimension to that? And last but not the least, can it be prevented? So we have to deal with all these topics. We have to think about this, because just by one lecture or just by one presentation, we may not, even I also am not able to understand why people commit crimes and violence. The violence against, my focus on this lecture will be why violence against women is more. The United Nations defines violence against women as an act of gender-based violence that results in or is likely to result in physical, sexual, psychological harm or suffering to women, including threats of such acts, coercion, or arbitrary deprivation of liberty, whether occurring in public or in private life. So it's not only inflict the injury, but in deprivation of liberty is also important. Not only in public, but in private life is also important. So the violence is not what we are getting reports in the newspapers or in the television or in the media, but it is even beyond that. So violence can be of many types: physical, psychological, sexual, economical, and controlling behavior also. And if you see all these five types of violences, then one must understand why I'm talking about violence against women. We always say in Marathi, we say Satchat Gharat, that a girl should be back to the house or home in the family after 7 p.m. in the evening. But that is not the case with the boys. Even the Prime Minister, when he was giving his speech from Lal Killa, Red Fort on Independence Day, at that time also he mentioned that we should also look whether our son is also getting back to our house after 7 p.m. But we don't do that. So controlling behavior, even what a woman should dress, what is nice to her, what is not nice to her, this everything is decided by either parents or the husband or a society at large. So controlling violence, forget about physical, psychological, sexual, but controlling violence and economic. Now, economic violence is, we say nowadays that women is working, shouldering all the responsibilities with her husband, even economic responsibilities also. But most of the families still gone is that, means we always cherish that, looking into the picture that a boy is coming after getting a salary, giving the salary to the mother or giving salary to the wife. This is not a reality. What we always see in films or media is not always real. Even the salary of a woman also, she doesn't have a liberty to spend. So economic offenses, economic violence, and controlling behavior are also type of violences, which we never question. We only question about physical and sexual violence. There are many, when we talk about sex violence and violence against women, then we have to talk on gender-based violence. Because these violences are committed on them because they are women. Violence against women and girls, all sorts of violences, starting from eve teasing to rapes, trafficking. Why girls are trafficking more than boys? Though sometimes boys also are trafficked, but it's mostly a flesh industry dominated 99% by girls. Then even what you can say, girls are taken away from their house and then they are trafficked for the flesh market. So that is also the biggest crime. The girl which would have led a good life has to lead a life of a prostitute or a commercial sex worker. Domestic violence, intimate partner violence. We are now hearing the word that rape in marital life, rape in marriage relationship. I distinctly remember there was a study going on domestic violence when I was in Government Medical College Nagpur. So one of the administrator at that time was saying that what is the reason of testing what domestic violence is going on in the society? Because beating a wife is very natural. And then he jokingly said that you should see how many women they beat their husbands. But jokes apart, that was a very, very wrong comment. Domestic violence is a violence of any type in a domestic environment. And the brunt of this violence is taken by either a woman or the children. So beating a wife if she has not cooked proper food or not, it's very common. I will even tell you about the figures of this domestic violence, which was very high. It has come down somewhat, but not yet up to the mark. Other harmful practices like genital mutilations and other things in some religions, in some countries, they are very much common. Sexual violence, rape, molestation, eve teasing, these are also very common. Stacking of women, child, early and forced marriages. One of the biggest crime which is still going on in our society is a child marriage. Child marriage is one of the best example of child sexual abuse. But that is going on. We have to understand that. Systemic rape during armed conflict. We have heard that whenever there used to be a war, those who won the war used to take the women of the defeated side and rape them, or they used to take them with themselves, keeping their all family, children, and husband and other persons at that place. Rape within marriage or within dating relationship, that is also very common. But that is not come to the limelight. People very less they complain about this sort of sexual violences. Rape by strangers, that is most often we are talking or we are listening or we are reading. Unwanted sexual advances or sexual harassment, including demanding sex in return of favors. Sexual harassment while going from walking on the roads, while sitting in a crowded bus or train, while watching movie, or at workplaces also. That is very common. Sexual abuse of mentally or physically disabled person, sexual abuse of children, forced marriages or cohabitation, including marriages of children. These are all sort of violence against women and sexual violences. Denial of the right to use contraception or to adopt other measures to protect against sexually transmitted diseases. There was very age-old taboo that was there in the society, or I don't know whether it is prevalent right now or not, that if a person is suffering from sexually transmitted disease and if he performs sex with a teenage girl or a virgin girl, he may get cure from these STDs. So people used to abuse and commit rape on those hapless children, girl child, forced abortion or denial of abortion. That also is some sort of sexual violence. Violent act against the sexual integrity of a woman, including female genital mutilation and obligatory inspection of virginity. Forced prostitution, we have already seen. So sexual violence is an act of sexual nature against one or more person or cause such person or persons to engage in an act of sexual nature or force or by threat, force or coercion, such as that caused by fear of violence, duress, detention, psychological operation and abuse of power against such person or persons or another person, or by taking advantage of coercive environment or such persons or persons incapacity to give genuine consent. So anything without consent can be termed as sexual violence. And it is not only related to one gender also. So people say that violence is not very common. It's only few cases which we are reported in the newspapers and on the media, but it's not that. You go and see this NCRB data that 4,15,786 rape cases were reported across India between 2001 to 17. On average, 67 women were raped every day across the country during these 17 years. Or in other words, about 3 women had been raped every hour. So if we are having this webinar of 3 years, 9 women would be raped in these 3 hours. So shocking. While 16,000 rapes were reported in 2001, the number rose drastically to 32,559 in 2017. 103% hike, really doubled. So due to education, due to industrialization, due to urbanization, we have not become good. We have becoming worse and worse. It's really painful to even present this. So what must be going on these hapless women? We can't even imagine. Again, violence again, lifetime physical or sexual intimate partners violence, mostly by husbands, 30%, 28.8%. Physical or sexual intimate partner violence in last 12 months, again 22%. Lifetime non-partner sexual violence, official statistics is not available. And child marriage is to the tune of 27%. So it's very rampant in the society. So what are the causes of sexual violence? The Groth, a psychologist, given 3 types of rapes, because rape is considered as the biggest sexual violence. Anger rape, power assertive rape, or sadistic rape. Anger rape is just to humiliate or debase or hurt the victim. What we are seeing, these are the anger rapes. What we saw in the Nirbhaya case or in the Hyderabad case. These people have anger about something else. But woman is an easy victim. If they are in group or 2-3 people and a woman in difficult situation is there, they can catch hold of that woman and commit the rape, even murder her also. These type of offenders attack their victims by grabbing, striking and knocking the victim to the ground, beating them, tearing their clothes and raping them. The experience for the offender is one that is of conscious anger or rage. Whatever they are of angry of, they just want to take revenge of the society and terming the woman as an object of that revenge. That is very bad. For that, these rapists, sex is a weapon to defile and degrade the victim. In some relationship also this happens. Because that person is angry with that girl, he will commit rape. He will even murder that. Because most of the murders, they take place because the woman who is raped should not complain. So that is very, very heinous crime in today's circumstances. Though we are learned, we are educated, but still the violence against women has not yet, what you say, can be totally prevented or eradicated. power assertive rape. For these rapists, rape become a way to compensate for their underlying feelings of inadequacy and feels their issue of mastery, control, dominance, strength, intimidation, authority, and capability. Because there are chances that women are now working at par with these men, they feel insulted, intimidated. They feel inadequate. And that's why, just to show that I am more powerful than you, these type of rapes are committed. And what happens, many times the rapist for one or two occasions may not complain. And then this becomes the habit and it becomes repetitive or compulsive. And that's why this Me Too campaign, though people say that why she did not complain 15 years back or 10 years back or 2 years back, that may be the reason. That girl or that woman could not muster the courage to complain about that rape, sadistic rape. They're sadistic in nature. Giving somebody pain and experience the pleasure is the basic of this sadism. And because of that also, they rape the women. That women in pain becomes an erotic stimulation for them. I'm going very fast because I have to finish. This is a very long topic, so I have to finish it in 20 minutes. So I'm going fast, but try to understand that it's not only the biology. There are many other social constructs also playing an important role in committing violence against women. And I consider that the victims of this are women and as well as these men also, to whom we have to educate, we have to give them the correct knowledge so that the violence can be minimized and these abusers can be minimized. The propensity models of sexual aggression, cognitive and attitudinal biases, forms of sexual aggression come from false beliefs of gender relations, misdirected objectives that only dating to have sex. I will date only to have sex. I don't want to have further commitments and other things which are present in love. Neuropsychological processes, difficulties in self-regulation, executive functioning problems, perception or memory system problems, arousal or motivational system deficits, and problems in action selection systems. These difficulties arise when sexual aggressors are not able to understand their emotional state and when confronted with a situation that trigger their arousal motivation system. Deviant sexual preferences. Focusing on deviant sexual preferences propensity model suggests that people who perpetrate acts of sexual violence are sexually aroused by non-consensual sexual interactions more than consensual sexual interactions. So pornography and all other things, that also is somewhat sometime also related to sexual violence in today's time. Personality disorders and traits, insecure attachment, insecure personalities, antisocial personalities, they also are more prone for rapes or sexual violences. Or narcissistic personalities also. They say that these individuals with narcissistic personality traits are more likely to interpret refusal of sexual advances as insult and in turn will have an adverse reaction to such insult. So because that man feels that she has insulted me by denying my sexual advances, now he will rape her. That is his psyche. And these are the personality problems also. There may be some individual factors. Known victim, the person knows this is usually common in child sexual abuse, but also common. The person knows that even if I do something, first time I will not be complained to anybody. So he commits. Then drug facilitated sexual assault, this rape, dating rapes and all. Sexual gratification is my right. I am a man, so I will do that. And many psychological factors. So research on convicted rapists, what they tell, that male rapists had less empathy towards women who had been sexually assaulted by an unknown assailant and more hostility towards women than non-sex offenders and non-offender males and females. So this is what these rapists they were having in their mind was studied. Even there was a meta-analysis that combining of many studies together, what that indicated that convicted rapists demonstrate greater sexual arousal to the scenes of sexual coercion involving force than do non-rapists. So forcing is constructed, forcing and sadistic pleasure was the main reason in this convicted rapist. There may be social factors, childhood environments that are physically violent, emotional unsupportiveness, characterized by competition for scarce resources, have been associated with sexual violence. Sexual aggressive behavior in young men, for instance, has been linked to witnessing family violence and having emotionally distant and uncaring fathers. I always say that a mother always looks after her daughter, but the fathers, they don't look after their sons. We should rear our son properly. We should be very caring fathers to sons. The domestic violence also is one of the important factor. If a father is beating the mother in front of a son, then it's very likely that he considers that it is a normal social norm. Family honor and sexual purity. Because family always responds that the woman is responsible for it. Because she was not dressed nicely. That's why she was harassed. That's why she was raped. This is a total nonsense. Absolutely wrong. But people think like that. You have to change that feeling, that thinking. There are social stressors like war and natural disasters. We have seen that winning army rapes the defeated soldiers' wives or the population, women in the population. Poverty. The poor woman is more abused because it is considered that she may not complain, or even if she complains, the money can be given and she can be kept mum, forced to keep mum. Physical environment also can lead to sexual violence. These risks include being subjected to violence by their families, prosecuted for sex outside marriage, being forced to marry their rapist. Now, this is the response of the family, or even sometimes it was even accepted by courts. Just few days back, the Supreme Court, Honorable Supreme Court, said that you have to stop this. Stop asking a rapist to marry a victim. Because raping is just not doing the sex. It's insulting that woman's modesty. So, being forced to marry the rapist or forcing the rapist to marry a victim is not a correct way. Social norms. Sexual violence committed by men is to large extent rooted in ideologies of male sexual entitlement. Belief system that women extremely few legitimate options to refuse sexual advances. This is creating the problem in marital life. Some men thus simply exclude the possibility that their sexual advances towards a woman might be rejected, or that a woman has the right to make an autonomous decision about participating in sex. They don't accept that right to a woman. And after marriage, a man feels that whenever he is interested, his wife should accept to indulge in sex. That is not correct. Social norms around the use of violence as a means to achieve objectives have been strongly associated with prevalence of rape. So if society is more violent, rapes will be more. Male superiority is strong, sex will be more. Countries with a culture of violence, rapes will be more. Rapes will be more. And that's why we find rapes more and more in many states and countries where violence is more. Now, what are the consequences of sexual violence? It's not only a trauma to a woman. There can be fatal outcomes also. Some woman may commit suicide because her modesty is outraged. She has been insulted. And the society is like that people may feel that she is responsible. So many women, they commit suicide. Or there are homicide we have already seen in many cases. There may be AIDS-related fatal outcomes also, or sexually transmitted infections also. Non-fatal outcomes can be either physical or psychological. Physical consequences can be unwanted pregnancy, infertility because of some infections, sexual dysfunctions, because that sex, either in the early life, can be a trauma to a woman whenever she wants to indulge in a sexual activity with her loved one, chronic pelvic pain, sexually transmitted infections, and obesity or anorexia. Urinary tract infections, gastrointestinal disorders, gynecological and pregnancy complications, migraines and other frequent headaches, fatigues and nausea. There can be many other things. We are only describing what is being reported by these women. There may be psychological consequences, post-trauma syndrome, shock, depression, post-traumatic stress disorder, social phobias. That girl may find every man as a rapist, shock, increased substance abuse or use or abuse, and denial of these situations. Fear, confusion, anxiety, guilt, depression, alienation, eating disorders. There can be plenty of such psychological reactions after this sexual violence. May not be always rape, but even any sort of sexual violence. So prevention of sexual violence. Can we definitely prevent? My last question when I started my talk was that, is sexual violence preventable? Primary prevention helps create environment where we can be more confident that people are safe in their relationships, homes, neighbors, schools, workplaces, or in any environment. Because primary prevention, as everybody of us knows from community medicine, that it is before the disease starts. So can this be possible? And of course, I think we can work on it. Remember, sexual violence is preventable. The key is to create and sustain healthy norms in our communities. Communities are vital in the development of preventing strategies. So we can do something to prevent. Now, when we talk about prevention, we never talk about eradication. Prevention means taking a disease to such a lower limit that it may not be a public health problem. Now, as the figures I shown you earlier were so horrible that we have to work very hard for this to achieve. But we can definitely start strategically and prevent the sexual violence to the very, very minute level or to the large extent. And it can be at the very minute level. Now, spectrum of prevention can be a wide, it's not only single activity related, but it is a very wide spectrum of activities. And what are they? Starting from strengthening individual knowledge and skills to promoting community education regarding sexual violence and prevention, educating providers who can provide this knowledge and skill to the public. So creating educators. Educating providers means creating educators, fostering coalitions and networks, different societies, changing organizational practices, and influencing policies and legislation. Changing organizational practices, a current example I can give, that previously women were not given long-term commission in our military services or armed forces. But now, through legislation, through code, they have been permitted. Even Supreme Court also told that they should be allowed to have the long-term commission in service. Now, where we can have these preventing strategies? These strategies can be started from family, schools, society, organization, and national or policy makers in the parliament, in the assemblies, in the legislative houses. So knowledge and skills, enhancing an individual's capability of preventing violence and promoting safety. Strengthening individual knowledge and skills involves transferring information and skills and increasing an individual's capacity for preventing sexual violence. We have to build up the capacities, skills. Skills are based on knowledge. So this, whatever I am telling, we'll have to tell it to the society. For example, physicians advise in reduction of morbidity, mortality, risk behaviors and risk factors and increase in healthy behaviors. That can be one thing where we can reduce the morbidity in women. Safety behaviors has to be inculcated. Healthcare practitioners can engage patients to promote healthy relationships and healthy sexuality. So by providing multiple sessions, we can do that. I'm going fast because I have to finish within the stimulated time. So what we can do, what IMA, what CACPI, why IMA Initiative on Sexual Health, what we can do, or I can say that this is our initiative. I propose this. So maybe the IMA office bearers at state, national, and local level can think about it and start it. And maybe our CACPI members can be associated with them. Let prepare a program for our members nationwide. Ask each member to conduct such programs in groups of children, in school, colleges, and for their parents and teachers. And in this, enable these individuals to prevent sexual violence against them or against the women and girls. Then promoting community education through mass media. Walk a mile in her shoes. What a woman feels when her modesty is outraged. That one has to understand. That can be done very properly through mass media, stage shows, community plays. There are a number of things that we can start doing that. So CACP and IIS initiative again can be, we can develop some programs on sexuality education, gender equality, and prevention of sexual violence by individual members in their cities, in various clubs, social organizations, for police personnel and judiciary. We can start having dialogue and sensitize the local media. This can be done as an organization. Educating providers. Now we have to educate or give the education to the providers, means one who can educate the people again. So who can be these providers? These providers can be journalists, building owners, managers, movie producers, librarians, staff at senior centers and recreation centers, radio stations, DJs, prison guards, bartenders, insurance policy agent, or any individual for that sake. And that's why we should organize workshops on such groups at regional, local, state, and national level in various languages, so that we can educate these providers, and then they will again start working for prevention of sexual violence. Fostering coalition and networks, bringing together groups and individuals for broader goals and greater impact, because they increase the critical mass. Then they can influence the society, they can influence the policymakers. That's why coalition and networking is more important. It's not only one organization which will be able to do that, but all the organizations like IMA, CACPI, FOXY, there are many other organizations which can do that. So coalition with professional bodies, NGOs working in the area of maternal child health, and international agencies like UNICEF, UNFPA, etc., can be involved in this. So a greater partnership and networking and coalition is more important in preventing this. So it's not only one spectrum or one stage, it is a multi-stage and multi-level action plan is needed. And changing organizational practices, adopting regulations and sharing norms to prevent violence and improve safety. Change in organizational practices can also catalyze their other social sexual violence preventive efforts. For instance, a media outlet may choose to restrict advertising negative portrayals of women and men in color, which could raise awareness and influence advertising campaigns. Healthcare institutions can establish workplace policies in alignment with ending sexual violence, including anti-harassment policies and modeling of egalitarian relationships. So implement environmental safety measures such as adequate lighting and emergency call boxes, complemented by community education and enforcement of policies, and encourage insurers to provide healthy sexuality promoting resources and materials. So this is avoiding the sexual harassment at the workplaces. And lastly, I think that slide is missing, that working at the national level or at the policymakers level, because I just the one slide which I will end with that slide. Yeah. So influencing policies and legislation. But once we start this all other above five activities, we can't influence policies and legislation. But at the same time, we cannot just wait all these activities to occur, but we have to influence the policy makers and legislation also. So it is very good that the many courts, high courts and Supreme Courts, they are now well aware and they are giving good decisions while ending with the gender-based violence or preventing or reducing this gender-based violence. So my humble request to all the people who are here is that start initiating a dialogue with your colleagues, friends, or other members in the society on this very, very important aspect. Because if this violence is going on, we cannot see our family members, our sisters, our daughters, our wives, our mothers be safe in this environment. It is a right time to think about all these things together. Then only I think we'll be able to prevent it to the maximum extent. So the take-home message can be, there can be only two take-home messages, that sexual violence, as we feel it, is not that less. It's very wide and rampant. And the second take-home message must be that this sexual violence or gender-based violence is preventable, provided we all become aware of it and start working in a coalition and in a network. So thank you very much for patient listening. I thank you all. I thank all the organizers for allowing me this topic to present in this webinar. Thank you. Thank you very much.
Thank you, Sanjay. Thank you, Dr. Sanjay Deshpande, for giving such a nice presentation on such a difficult topic. And you there at national level as a convener and with CACPI chairperson, we can definitely work together and go ahead to prevent this sexual violence, and we should promote this as suggested by you. We will work together.
Thank you. Thank you very much, Archana.
Thank you.
Now I think last, because I did not touch about the violence. You cannot compare two violences, but gender-based violence and even heinous of it is a child sexual abuse or violence against sexual violence against children. That is very, very horrifying. One even cannot think about it, but people are committing it, unfortunately. So what is child sexual abuse? I request my very dear friend and colleague in IMA and in Nagpur, Dr. Kush Jhunjhunwala, to throw light on it. Dr. Kush Jhunjhunwala is the immediate past president of IMA Nagpur. He is very, very active in IMA activities. He is the co-chairman or co-convener of IMA MS PPS, Professional Protection Scheme. Also, he is very associated with Indian Academy of Pediatrician, and he was secretary of IAP Nagpur also. A very humble and sincere person. I request Dr. Kush Jhunjhunwala to start his presentation. Dr. Kush, please. Dr. Kush, are you there?
Yes, he is not here, sir.
Why?
I'm not sure, sir.
No, he is here. I saw him.
I saw him here, but right now I guess he has dropped out.
Dr. Kush. I am trying Dr. Kush on phone. In the meantime, I request Dr. Archana to, if there are any questions, you can ask the learned panelists or speakers. In the meantime, I will contact Dr. Kush. अरे बाप रे, फिर
There is a question that by Dr. Sanjay Devtare, that
Yeah.
are females becoming more sexually violent due to more exposure to modern media?
I think that question needs to be answered. I will ask Dr. Padmini Prasad. Dr. Padmini.
Anyone can answer, I think.
Okay. No, that is not, I think, is not correct observation, because this is what we have some sort of, what you say, certain bias regarding female sexuality. And that's why I was actually thinking about that Dr. Padmini must be the right person to answer. Dr. Manjusha Giri, our MMC observer, is here. She is also a psychologist. I request Manjusha to answer this.
Madam, can you please repeat the question?
Yes, I'll repeat. Just wait.
Or Archana, you also can then add to that.
Are females becoming more sexually violent due to more exposure to modern media?
To answer this question, I would like to say females are becoming more aware about sexuality and their needs, and they are starting expressing their needs. That's why we are feeling like they are becoming more violent. And definitely there is some impact of social media also, and those channels like pornography and all. There is some part of violence, but I will say females are becoming more aware about their needs.
Okay, Archana, you also can add. Being a woman, you also can add on that.
I would say this is not because of only the exposure to modern media, but I think as such also females are becoming more violent because of the independence they are getting.
Okay. Yes, yes.
Because पहले ऐसा था ना कि if you have to
नहीं, इंडिपेंडेंस का सवाल ही नहीं उठता मैडम. पहले लोगों फीमेल्स को पता ही नहीं था, and they were not given that priority.
The priority was husband and husband's need, not her needs. And
Request Dr.
violence
Reddy also to comment on it.
Violence.
Yeah, that's right. As women are aware of their needs nowadays, that's why they are becoming aggressively asking for their needs, to complete their needs. And it may be taken as a violence. I feel like this.
Yeah, and even if the domestic violence or violence against men is increasing, but if you say the percentage of it, I just read it sometime during preparation of this presentation. It is not even 1% of the total violence against women. If the question, Dr. Devtare will like to have.
Lot of questions from Dr.
I can
Sanjay.
give the reference also for that. During my
Lot of questions from Dr. Sanjay Devtare. Sexual violence caused by babas or sent. Most of them are underreported. Your opinion about it?
Absolutely. Yes. Because the men-dominated society, women feel insecure even complaining also. She doesn't have courage to complain against the sexual crimes because the society, what society say, I told in my presentation also, that society often finds the woman or girl guilty of it. The blame is put on the women and girls because bad shit went there.
I will say
it is very easy to put the blame on a female.
Pardon?
It is very easy to put a blame on a female.
Yes. Okay, Dr. Kush is here. Yes. I think, Dr. Kush, you can start your presentation.
Yes, definitely, sir. Thank you.
Yes. Thank you. Thank you. Thank you, Manisha. Sorry, thank you, Manjusha, for
Thank you so much.
Yes, yes, yes.
Manjusha, you received the bouquet as MMC chairman, I think.
मिळाला मॅडम नाश्ता
Virtual,
पण मिळाला
virtual. नाश्ता पण मिळाला. Okay.
हो.
Hello.
Yes, yes.
Hey, can I request the DigiShare person to kindly share my slides?
Have you sent them?
Yes, sir.
Sure,
On the
sir.
email.
Sure, sir. Definitely. Give me a moment.
Yes, sir.
Or else, if you want to share, you can. What you can really do is open the presentation first and then share the screen.
Okay, I will try to do it.
Yes, sir. Else, I will do it for you. Sir, you need to stop the share screen option first.
Okay.
Okay, it's already opening, so not a problem. So you can share the screen now again. Click on share screen again, sir.
Yes. Okay, done.
No, sir, we are not able to see. Yes, sir.
Okay. Is it visible now?
Yes, sir.
Okay. So good evening, everyone. Basically, respected seniors and colleagues. First of all, thank you all to the IMA initiative on sexual health. And at the same time, IMA, my parent branch, that is IMA Nagpur branch, along with CSCPI, for conceptualizing this important CME. Special thanks to my mentor, Dr. Sanjay Deshpande sir, Dr. Balasubramaniam sir, who is the chairperson of this committee, Dr. Ashna Kothari, our president, and Dr. Rajesh Sarbande, a secretary, IMA Nagpur. Special sense of appreciation for our beloved National President, Dr. Jailal, and respected Honorary Secretary General, Dr. Jayesh Lele sir. Sincere regards to respected Dr. Narayan Reddy sir, Dr. Venkataraman sir, as well as Dr. Padmini ma'am. Last but not the least, a young MMC observer. She is there in the screen. Good evening, Manju ma'am.
Good evening, Kush.
Good to know that my lecture has been kept after stalwarts of sexual health as well as knowledge in India. So it is just like an IPL. I think IPL is going to start from 9th of April, but I think this is just like an IPL because now we have seen triple centuries by Dr. Padmini ma'am, Dr. Reddy sir, Dr. Sanjay Deshpande sir, Dr. Venkataramana sir. So I'm just a tail ender, and you can call me as a night watchman. So as you all know that child sexual abuse, this is supposed to be the most heinous crime in the world. And the bruises will heal, but the scar will remain for a lifetime. And I think there is no greater evil than those who willingly hurt an innocent child. You all know this Me Too movement. This Me Too movement, which with variations of related local as well as international names, it was a social movement which was started against the sexual abuse and sexual harassment, where people publicize their allegations of sex crime. The phrase Me Too was initially used in the context on social media in 2006 by a sexual harassment survivor and activist Tarana Burke. And basically it was done to see and to create an awareness as well as empathy policy, so as to change the policies and the laws which are related to sexual violences, as well as to have some reforms and a good implementation of the law. The Me Too, you will be surprised to see and know that there was a bill was passed in the US Assembly, which was known as an Me Too bill. And the purpose of this bill was to change how the legislative branch of the US federal government treats sexual harassment cases. In 2018, we also saw the rise of Me Too movement in India, inspired by a global campaign against sexual violences, harassment, as well as the women across the spectrum open up and share their stories about abuse by men in position of power. The child sexual abuse is a subject that has received much attention in recent past. And historically, it has been a hidden problem in India, largely ignored in public discourse and by the criminal justice system of India. India is the second most populous country in the world, and of it, nearly 19% of the world's children, they live in India. So India has one of the largest population of the children in the world that is vulnerable to all the types of abuses, neglect, as well as exploitation. Of the total population in modern day India, about 44% are under 18 years of age, and 1 in every 2 children is deprived in terms of not receiving primary education, adequate nutrition, as well as medical care. The child sexual abuse, it's a worldwide problem, and my job was made easier by Dr. Sanjay Deshpande sir by giving the statistics of the current statistics of sexual abuse in India. As always, Dr. Sanjay Deshpande sir is always there to help me out and to make my life easier in each and every front of life. You'll be surprised to know that 4 children victims are there every hour. And between January 1st, 2019 to June 30th, that is the first 6 months of 2019, we had an exponential jump of 24 to 25,000 cases of child abuse, which has been registered in India, which means 4,000 cases in a month and 130 cases in a day. So, as you know, India is home to one of the largest number of the sexually abused children in the world, but there is a general reluctance to talk about the topic, so the real number could be much higher. In India, the protection of children by the state is guaranteed to Indian citizens by an expensive reading of Article 21 of the Indian Constitution, and also mandated given India's stature as signatories to the UN Convention on the Right of the Child. The UN Convention on the Right of the Child was ratified by India in 1992, and it urges the state to ensure the right of the child to protect from abuse, violence, neglect, as well as exploitation. These are all India's shame. I think you all know the Kathua rape case, Uno rape case, that infamous 2012 Delhi gang rape case, the Rana Gate case. Even today, there'll be 3 to 4 cases of gang rape, child sexual abuses daily in newspaper. And the most recently being yesterday's Times of India, where there were 2 cases of adolescent rape case, one in Mathura and the second was in Meerut. And the victim of the Meerut, she died at the gate of her home. Last month in March, there were 2 major cases, which the infamous cases you all know. One was from Hathras, where an accused in an assault case, the case was that of 2018. And the person who was out on bail had reportedly shot dead the rape survivor's father in Uttar Pradesh recently, Hathras. And the second was the father of a 13-year-old gang rape case has been killed in a road accident in Kanpur district. And most probably that was not a genuine road accident. Basically, it was a murder. So technically, the World Health Organization, it defines the child sexual abuse as the involvement of a child less than 18 years in sexual activities that he or she does not fully comprehend, and at the same time is not able to give informed consent to, or for which the child is not developmentally prepared and cannot give consent. There are different types of sexual assaults or child sexual abuse, like sexual assault, exploitation, as well as grooming. The term assault basically defines offenses in which an adult uses a minor for the purpose of sexual gratification, for example, rape, groping, and sexual penetration with an object. The exploitation, basically, it's a commercial transaction of sexual abuses, offenses in which an adult victimizes a minor for advancement, sexual gratification, or profit, for example, prostituting a child, live streaming sexual abuses, etc. And basically, grooming is a term which is establishing an emotional contact with the child and sometimes with the family to lower the child's inhibition with an objective of sexual abuse, and thus to lure the minor into various illicits such as child prostitution, child trafficking, and for example, an online child room. So what are the factors that facilitate the child sexual abuse? Poverty, that is supposed to be the biggest factor, but now it has also been seen in rich families, overcrowding, extended families. There are abundance of street children in India, but by no means it is exclusive to India. Admittedly, their impact might be exaggerated or intensified given the population density as well as the size of a country. Thus, a complex mix of individual, ecological as well as situational factors are said to facilitate the child's sexual abuse. And in 95% of the cases, the abuse is known to the child or the person who has been sexually abused. And you'll be surprised to know that only 10% in 10% of the cases, the strangers are the offenders. In India, only 3% of the child sexual abuses cases, the offenses are reported to the police, as over-criminalizing and over-punishing this offense is counter-initiative and likely to deter reporting. So, sexual offenses against children are massively underreported due to the culture of shame and silence in our country, which is further intensified by the fact that nearly 95% of them, they are known perpetrators. They are related somehow to the victim. There are certain myths and facts which are associated with child sexual abuses, like children tends to forget incidents of sexual abuse after some time. Children sometimes enjoys being sexually abused. Sex education increases the incidence of child sexual abuse. Basically, it's a result of the Western media. Good-looking children are more prone for sexual abuses, and the girls are sexually abused and not boys. Why a child may not disclose abuse? That is a bigger question. And basically, what I think is because the child, they do not have any language. They feel they are hurt by betrayal. They are helpless with powerlessness, and they are struggling with stigmatization, which is associated with sexual abuse. The child blames himself or herself and thinks the abuse is their fault. The abuser is a known person, and the child does not want to get them in trouble. But at the same time, the child is very young and it is not aware that he or she is experiencing is basically a sexual abuse. So this exactly goes into a mind of adolescent, because what he thinks is that if I tell you I was sexually abused, will you judge me, believe me, see me as a less of a man, add to my sense of shame? So if a child talks to you about sexual abuse, it is important to listen carefully to what they are saying. Let them know that they have done the right thing by telling you. Don't confront the alleged abuser. Explain what you will do next. But at the same time, the rape of a child, you should know, and you should think that rape of a child is a violent act of contempt. It is not an expression of sexuality or affection. So believing and supporting the child are two best actions to start the healing process. During the past 30 years, the focus on the extent and the nature of the child abuse and the neglect has been coupled with an increasing interest in the impact on child development, its health, and the mental well-being. There are certain long-term effects of child sexual abuse. The survivor may have a difficulty in externalizing the abuse, thus thinking negatively about themselves. And basically, the child sexual abuse has been related to higher level of depression, guilt, shame, self-blaming, dissociative pattern. And after years of negative self-thought, survivors have feeling of worthlessness and avoid others because they believe that they have nothing to offer. Then they can have regular nightmares, sleeping difficulties, and at the same time, there's a post-traumatic stress disorder. There could be a nervous breakdown, basically, which is seen in adolescents. And they can have problems of sexual desire and sexual relationships in later part of their life. So they could have difficulty in forming attachments, difficulty making romantic or intimate relationship, and these all can be overcome if consistent long-term emotional support from family members and parents are there. Remember, abuse is never contained to a present moment. It lingers across a person's lifetime and has a pervasive long-term ramification. Because this is absolutely true that we can deny our experience, but our body remembers. What is the role of mental health professional? They have a very key role in assisting the child and his family, because they can take a detailed history of the family background, and with specific emphasis on parental practices and the type of family interactions. They can assess dysfunctional families. They can help the child narrate the incidents, that is known as catharsis, and undergo a complete catharsis, as well as in handling the range of emotional conflict which is experienced by that particular victim. They can also have a psychological debriefing, which provides emotional and psychological support to the child to prevent development of post-stress disorders and all other forms of negative sequelae. But the most important point is you have to install hope, because attempt a positive resolution of the traumatic experience of the child and help in reducing the obsessive deterioration of self-respect when the child becomes to believe and trust that a change is possible. And according to me, hope never dies. What is the treatment part for child sexual abuse victims? The initial approach to treat a person who has been a victim of child sexual abuse is dependent upon several important factors: age at the time of presentation, as well as the circumstances of presentation for the treatment. And the goal of the treatment is not only to treat the current mental health issues and trauma-related symptoms, but also to prevent future ones. The three major modalities for therapy with children and adolescents are family therapy, group therapy, as well as an individual therapy. But which course is used depends on a variety of factors, and that must be assessed on a case-to-case basis. For instance, treatment of a young child generally requires strong parental involvement and can benefit from family therapy. But adolescent tends to be more independent. They can benefit from individual as well as group therapy. Now, this is regarding the laws in India. So, child sexual abuse laws in India have been enacted as a part of the child protection policies of India. And it was way back in May 2012 that an act came into play. The POSCO Act was enhanced in 2012 to provide a robust legal framework for the protection of the children from offences of sexual assault, sexual harassment, as well as pornography, while safeguarding the interests of the children at an early stage of judiciary process. The distinctive features of POSCO Acts: it was enacted to address criminalizing a range of acts, including child rape, sexual assault, harassment, as well as pornography involving a child which is under 18 years of age. It requires a special treatment of cases relating to child sexual abuse, such as setting up of special courts, special prosecutors, and support persons for child victims to facilitate speedy trials in cases. It provides for a stringent punishments, which has been graded as per the gravity of the offences. The punishment, it ranges from simple to rigorous imprisonment of various periods. There is also provision of fine, which is to be decided by the court. Then offence is also treated as an aggravated offence when it is committed by a person in a position of trust or authority of child, such as member of security forces, police forces, public servants, police officers, etc. And there were major impediments in the implementation of the POSCO Act. The Act has faced unforeseen challenges in its complete implementation. Its implementation is pathetic in the country, and the pace of the enforcement is very slow. While the cases registered under POSCO Acts are constantly on the rise, including total grand rapes, you'll be surprised to know that the rate of conviction is just 4%. And at the same time, the acquittal is just a shameful 6%. The pendency of the cases is to the tune of 90% as per the National Crime Record Bureau. So high dependency of child sexual abuse cases render POSCO a toothless law. So some of the notifiable challenges which was faced in the enforcement of the Act since 1912 seems to be certain administrative pitfalls. And as per the provision of the POSCO Act, the state government in constitution with the Honorable Chief Justice of High Court should designate a session court as a special court to try offenders to facilitate the speedy trials. But despite the statutory speculations that every district should have an exclusively POSCO court, the directives has been continuously ignored. There was a lack of expertise to handle the cases, and to make the matter worse, the honorable judges appointed to handle are not subject experts, as neither they are provided an additional training by the state government. There are certain other challenges which is also faced for implementation of this forceful act, where the children who have been sexually abused, thereafter of a trial is perhaps a more concern than the act of getting justice through a potential conviction. So what is the need of the hour? You should have a multidimensional approach, speedy trials. Similarly, doctors also needs to be trained. And in this regard, the onus lies with the state government, the central government, the Chief Court, Supreme Court of India, the police department, the judicial system, the medical fraternity to implement the act in letter and spirit and to respond to these cases with an urgency, empathy, compassion. There are possibilities. And these speedy trials, they are only possible if the honorable judges, the staff, the prosecutions, police, and the defense, they coordinate with each other, which is still not there. failing which the concept of special courts will be defeated. And at the same time, doctors also needs to be trained because they understand the intricacies and the help in proper scientific collection of various evidences while examining the child victim of sexual assault. So is this the right time to amendment the POSCO Act? There has been rising the crime over the children in the country in the last year. As per official data, there are 12,000 cases were registered in a single year in 2019. So again, there was an increase in POSCO cases by nearly 45% between 2017 and 19. And you'll be surprised to know that there was a 22% jump in cases of child sexual abuse in 2018. There was a 28.7% jump in cases of child sexual abuse in 19. And it is a fact that there has been an increasement of POSCO acts by nearly 45% in last 2 years, from 32,000 to 45,000. So I think this is the right time for an amendment of the POSCO Act. And yes, in a move to deal with cases of child sexual abuse, our Union Minister Smriti Irani had introduced a bill in the Rajya Sabha on 18th of July 2019 to amend the Protection of Children's Sexual Offences Act, that is POSCO Act, that aims to make punishment more stringent and even include death penalties for offenders involved in sexual crime against minors, thus making it more stringent. So the Honorable Minister said that recently the POSCO Act was amended, making online pornography as well as online sexual abuses of children a penal offense. We now have national database of sexual offenders in our accounts. Recognizing the fact that justice delayed is justice denied, the government has set up monies as well as access to the justice by ensuring 1,023 fast-track courts, which are set up across the country in 1 year, so that the cases of crime against women and children can be expedited and access to justice becomes a reality for our citizens. Some of the significant additions in the new rules include provision of mandatory police verification of the staff in the schools and the care homes, procedures to report sexual abuse materials, that is pornography, imparting age-appropriate child right education, among others. The Act has also removed the word communal or sectorial violence, which has punishment for a person who sexually abused a child during the course of such violence. The word has been replaced with violence during any natural calamity or in similar situation. It also has crackdown. It also has a crackdown on child pornography. The Act has also tightened the provision to counter child pornography. While the earlier Act had punishment for storing child pornography for commercial purpose, the amendment includes punishment for even possessing the pornographic material in any form involving a child. Then, even if the accused person, there were certain amendments like zero tolerance to violence against children. They have recommended a periodic training to all the persons coming in contact with children, child helpline services, dedicated child helpline services with a number of 1098. And at the same time, they have also vouched for an orientation program for police personnel as well as forensic experts. So now the bill has also included administrating or helping the administrating any chemical hormones substances to a child for the purpose of attaining early sexual maturity as an aggravated penetrative sexual assault. The POSCO also makes the reporting of child sexual offences mandatory. In cases of failure to report, that person may face an imprisonment for 6 months, which is given in section 19 and 21 of the POSCO Act. So this is in a nutshell, there is a difference between the POSCO Act, which came into existence in 2012, and now the bill has been amended in 2019 to make it more stringent and punishable. So what is the role of doctors under POSCO Act? The doctors have a dual role. They are in a position to detect that the child has been sexually abused. For example, if they came across a child with an STD in their OPD. They are also often the first point of reference in confirming that a child has indeed been the victim of sexual abuse. The doctors and other medical professionals are involved at the stage of providing emergency medical care to the sexually abused children, as well as at the stage of conducting a medical examination. They can also assess the child's emotional as well as physical well-being and make appropriate reference and testify in the court when required. So what is the prevention for this? So we have to talk to the parents about the importance of teaching the children about their personal space and privacy by the age of 3 years. I think Dr. Manju Giri, she is there as an adolescent teacher. So basically teaching the child the concept of okay and not okay, touching, teaching the children to tell if anyone touches their private parts for a reason other than to provide care, teaching the children not to keep secrets, teaching the children the appropriate names for their private parts so that they have the language to communicate it, and looking at the signs that a child is being abused and take necessary action at that particular point of time. So how can I protect my children or my child from sexual abuse? I think the most important factor is parent-child communication, which can reduce the incidence of child sexual abuse and be involved in child's life and encourage our children to speak up. So strengthening community-level child protection system is also a key to prevention. Child sexual abuse is a preventable health problem that has been allowed to spread unabated due to the scientific and social neglect. Very well said by Christiana in her book, The Writing Journey from the Healing of an Incest and Family Betrayal. She's a sufferer, victim. The fear of amendment forced me to comply as a child, but I am not forced to comply anymore. The key people in my life did reject me for telling the truth about my abuse, but I am not alone. Even if the consequences for telling the truth is rejection from everyone I know, that's not the same death threat that I was when I was a child. I'm a self-sufficient adult, and abandonment no longer means the end of my life. So recently, a committee was constituted to suggest measures to curb the child sexual abuses recommended to the Government of India that offenders above the age of 16 years under POSCO Act should be tried as adults. But I'm skeptical about it because curbing sexual violence against children, it requires broader social reforms that are beyond the realm of the law. So much has to be learned on this front, and basically remember, this is the most traumatic experience a child can have in his childhood. So it's the time we stop hiding child abuses, and we have to break the impenetrable sexual abuse. Just look at the photo which is depicted in the slide, where a child says, I can't say and I can't stop it, but you can, because silence is deadly. So when you feel caught in a web of childhood abuse, find words to describe it. Write them, say them, express them in safe place with safe people. Thank you. So over to Dr. Sanjay Deshpande, sir.
Thank you, Dr. Kush, for an excellent presentation. It was a very, very good presentation. You have given all the facets of child sexual abuse, the psychological, the sexual, as well as the most importantly, the legal aspect, and how the doctor should go about it. That was an excellent eye-opener for all of us. And I know all of us will definitely be benefited out of it.
Thank you, sir.
Yes. Now, all the panelists and all the speakers are here. Dr. Archana, are you here?
I'm here only.
Yeah, there is only one question now because we have answered few of the questions of Dr. Sanjay Devtare. Dr. Mukesh Patel is asking why nowadays divorce case increasing in marital life. So I think Dr. Venkat and Dr. Padmini both can answer these questions shortly, in short time, because male sexuality and female sexuality. So Dr. Padmini can give the opinion on from the women's side. दोनों lawyer बन जाओ अभी. Both are advocate of women and men.
In present day, because of the increasing education, awareness, media, and there has been more and more, as I told you, there has been sexual emancipation for the woman. She is becoming a demanding individual, and she is able to think why I am not having this, why I am not having that, and all that. So that is why this right from the childhood, because nowadays both girls and boys are brought up in the same way. Girls are also educated, confident, and they have self-esteem, they will study, they go abroad, they work together. So the demand also is more. If the man cannot keep pace with her sexual expression or the concern, So most of the time, this frustration and quarreling, all that will start. But right from the childhood, we have to teach them some amount of tolerance and accepting the person, mutual cooperation, love, affection, because sex is not the only thing in marriage. So once they get married, even the slightest problem, the first day, if the man does not perform, she will just run away to her mother's place and start telling he is important. I cannot stay with him. How can I stay when he cannot perform or when he cannot give me satisfaction and happiness? So that's what I am seeing with more and more newly married couple. That is the first night can become the last night also for them. So that's how, because of these frustrations and all these things, so their this interpersonal relationship is getting affected. And once that is there, then they don't, because the taboo about divorce has gone in the society. So they are also more open instead of living in the such a hostile environment and disturbed interpersonal relationship. It is better to separate out, because second marriage, third marriages are also becoming common. That is how, once the taboo is removed, they are becoming more and more confident, and they don't want to have that relationship. It is not like earlier relationship, when once you are married for the lifetime, and somehow you used to put up with all the problems and carry on. I think the youngsters or the children, of course, we have to look into their interests and their desires and whatever their needs. But still, some amount of love, affection, mutual cooperation, and understanding. And whenever there will be problems. There is both sorrows and misery, and also the both sides, joys and sorrows. Both the things they have to understand and carry on with, because sex is not the only thing in marriage. There are also other things which count during the marriage. Once that side of mindset is done, I think many divorces can be prevented. And simple cases of sexual incompatibility, so many cases which have been referred by family court to me. Once you have corrected the sexual dysfunction, they have become the happiest couple. So they should understand that this is one of the reasons, and they should get counseling at the proper time. That is also important.
Dr. Venkat.
Yes, my lord. My client has applied for the divorce in the family court, not because of sexual dysfunction or sexual adjustment between wife and husband. It's because of the ego problems. Just because my client's wife is earning 1,000 rupees extra, she is behaving as if she is a master. That is making me unable to adjust with her. I console. My client has tried his level best to console her, but she is not listening. That is the reason. So, my lord, today, this youth are applying for, as rightly said by my opponent lawyer, that easily they are going for applying for divorce because of the lack of endurance, lack of adjustment capabilities. They are just dragging the twig for simple ego problems. And this is one way. And another way is, some patients are coming, some clients, my clients are asking, sir, when you are in youth, only Germans are preparing cars, one car for lifetime, one house for lifetime, one wife for lifetime. Now, plenty of cars have come, plenty of models have come. Companies are repurchasing them and giving new cars. The lifestyle trend has changed now. So why should we stick with the same old wife, same old husband? So this is the new trend that is going on in the community. So where are we going? Where are our medical system, legal system is going? So it's we have to introspect ourselves from legal and medical system. As a medical personnel, I request the CSCPA to take up this, preparing all the would-be married couple to undergo premarital counseling, where we can be preparing the prospective couples how to adjust, how to enrich the relationship so that marriages will stay for longer. Thank you, Millard, for
Thank
your
you. Yes. Thank you. Both the lawyers put their side well. but I am not a judge, so I can't comment on it. But my take on it is that it's definitely true that adjusting each other has become difficult nowadays because of the freedom, liberty, rights. But when there are rights in any relationship, rights come with responsibilities. That has to be understood. That is the most important thing for all the couples. I have one important
Now,
question.
my lord, please take the opinion of senior lawyer sitting there, Dr. Narayan Reddy.
Yes. Dr. Reddy, I have different question for Dr. Reddy. Dr. Reddy, are you there?
Yes,
Yeah, here only.
Yes, yes. Sir, during my presentation, when I started my presentation, I asked one question that in intimate relationship, what we see that there are couples who love each other so much, but suddenly one partner and usually the man in that relationship commits some violence, maybe a rape or even murder also. So my question was that is this love and violence are the two extreme poles of the same axis?
Definitely not.
Okay.
Love doesn't make somebody resort to violence. That's why I said in that romantic violence typology, one is maniacal love, like Dar, movie Dar and Bazigar, etc. Strictly speaking, that is not called love, but you can classify it. Going back to the question which both Dr. Ramana and Dr. Padmini answered, let me give you my take. Why are we thinking that this is bad, that is bad? Let us understand society is changing, society is evolving. All these things are bound to happen. Let us not judge it by the standards of yesteryears. See, from what our grandparents' time, things have changed to parents' time. Our parents' time, things have changed to our times. Our time, things are going to change to our children's times. So more than getting worried and then being judgmental, let us take it in our stride. And only thing we can try is to reduce the harm reduction. That's all we have to do it.
Thank you, sir. And one last one comment from all the esteemed panelists I want to have, that it is said that sexuality education with gender-based education or gender education can minimize the sexual violence. So I want the elite panel to throw light on this. Dr. Reddy, you first.
Yeah, it is more than gender-based or gender-related. What is important is a value education. Without value, teach them about gender, there's no point. So first, what we have to inculcate is a value education. Yes, and then based on that, you can always tell them how both the genders should live, coexist, respecting each other. That's important. But the first priority is value education.
Dr. Padmini? Okay. Dr. Kush,
Yes, sir.
you elaborated very well on child sexual offences and child sexual abuse also. How can we prevent it through this adolescent education or sexuality education? That is also one of the most important thing. I think it can be done and tried in many other countries also.
Yes, sir. So last year we have taken adolescent education programs for teachers as well as headmasters of school. Basically, we want to sensitize the teacher also, because maximum time what we see is, I think Dr. Manjusha Giri is also there. She was also there as a partner for this particular program. And Dr. Manjusha Giri, ma'am, are you there?
Yes.
I think we can have a comment from Dr. Manjusha Giri on that also.
Yeah, we can reach. We had a program in our tenure in 2019, training of trainers for teachers. Similar programs we can conduct at national levels and at various places through IMA and through conduct such programs. We can train them how you can recognize child abuse, child sexual abuse at earlier stages. Like
Yes.
simple tips you can give them. If your child is avoiding some time, some place, and some person recently, okay? If your child is favoring some person recently, okay? Increased anxiety, decreased interest in studies. If your child is inattentive, if child's concentration is losing, then we can predict earlier that your child is suffering from some trauma. We can predict that, and we can teach these things to teachers, how to predict an early pickup of these cases, and we can manage it earlier stages.
Thank you. Thank you. So
Yes.
training students, training teachers, and training parents.
Parents also.
All these three are important, and most importantly, then not a culprit should be free from punishment. Doctors also need to be trained so that they will
And
report it very correctly
more
and
than
promptly.
90% of cases, more than 90%, known person is there,
Yes.
either family member or friends of parents. So we have to be vigilant about these issues.
Yes.
Anything more? Because I think there is one question added. Yes, we have already answered that question, but the question was child abuse is difficult to prove. That is the biggest problem. Girls more interferes in married life is major cause of divorce. That we have already taken. So the take home message by Dr. Reddy is that we should not judge. The society is evolving, and because of that, maybe the things will be different. Women are more now able to take the decisions properly. They have they can sustain their livelihood by their own earnings. My take is only one, and I think everybody will agree. In Indian society, in a traditional Indian society, a single woman was not respected earlier. But now time has come that single women, single parent, a single woman parent is respected in our society. And I think if that happens, maybe divorce rate will increase. That is not in our hands. But definitely a woman will be respected. Dr. Venkat.
Mhm. Yes, as I told you earlier, my clients was telling that gone those days of one wife, one car, one house. So this is disposable syndrome is occurring. So as rightly said by my all speakers, let us respect that disposable system, respect the autonomy of each individual. If you want to educate them to reduce this divorce rate or child sex abuse, it is a double-edged weapon. Unless properly executed, it revert back, it bounce back. To get the desirable results, it has to be executed from top to bottom in the same manner with the same precision. Otherwise, it bounces back. Many times, many countries have tried and they have stopped it also. So it is a double-edged weapon. One should be very careful. If strict action plan from top to bottom to be implemented meticulously, if that system is there, yes, it works out. It gives the desirable results.
Yeah. So let us not judge a person, judge a couple who is taking a divorce. There may be their freedom or their own reasons to do that. That should be a
The only thing is, after separation, this fellow should not harass her. That girl should not harass this fellow.
yes, that's true.
Let them separate. Let them have their own autonomy. Then let them respect their autonomies. But that is not happening in the society. There are plenty of cases of where the girl is harassing the boy, boy is harassing the girl. That should not happen.
Yes.
That social malady has to be addressed. Who has to address? Again, $1,000 question.
Sir, here lies the role of premarital counseling.
Yes, that I advised, madam. I
That we
advised
should
the
do.
judge to put a
Yes.
committee. I
Yes.
advise as
Yes,
advocate.
yes.
I strongly advocated that.
No, this nowadays because of the increasing online the dating and online marriages, so many things are hidden. Their psychiatric problem and their personality disorders, and so there are also some genuine reasons for in some couples where it becomes impossible for them to stay together. So those situations there is no other go but to have their divorce. That's also there.
One very interesting question come. I think we will take it as the last, and then we'll ask our honorary secretary to give a vote of thanks. Reducing age of consent and increasing age of marriage. What was the effect on abuse?
Yes, not only abuse, more on the sexual experimentation, more on the STDs, more on the HIV, more on the unwanted pregnancies, more on the social turmoil. All it is responsible for all causes, but it is inevitable. As a senior judge or senior advocate, Narayan Reddy was telling
Yes,
that,
yes.
because let us go with the stream. So in that case, we have to bear this. The only thing is to minimize this. Sex education, proper scientific sex education will help.
Yeah. So before going for vote of thanks, one last request to Dr. Narayan Reddy, sir. Dr. Reddy, are you there, sir?
No, I guess Dr. Reddy sir is not here.
Okay.
One POXO Act, that one clarification with that POXO Act, because see, there is when a young adolescent comes for sexual abuse and becomes pregnant and comes for MTP, gynecologists have got a lot of problem. Because even if it is consensual thing or young girl or any girl less than 18 years, if she is pregnant or if she comes for delivery, we have to report it to the police. And on one side, there is a conflict of interest there. On one side, the medical termination of pregnancy allows us to do the termination. On the other side, POXO Act has got a stringent action on the doctor if he does not report. That's
Madam, though you are my opponent lawyer, I support here, but safeguard yourself. Patients will threaten you because it happened in Hyderabad. They threaten the doctor that if you report it to the police, I will see your end.
yes, that's what happened.
That's
And
why
not come to the doctors for medical termination. They were going to quacks and illegal abortion survey. They're scared that they have to go to the police station.
Doctor has been, gynecologist has been threatened.
Threatened, murdered, everything. All things have happened. So that's
no lie is there for that angle.
Sir, but if we don't report, then also we are threatened.
Yes.
Don't report.
If you won't report,
please
save your life.
If you won't report,
that is a double-edged sword. Double-edged sword.
Doctor is like a sandwich. If you won't report, legal system will threaten us. If you report, our life will be at stake.
There is a take-home message for Archana Kothari, madam. Save your life, ma'am.
By the say, what if some gang comes and stands with a knife? And,
It was a very nice discussion.
Because this is happening with the known people. They are bringing the child for help. When we suspect and say, don't bother doctor, treat it. Give some ointment, give some tablet. Don't make it an issue. This is how the things are happening.
So a long way to go. I can say, yeah, a long way to go.
And now the age of marriage also is there is one proposal that age of marriage for the girls should be increased to 21 years.
21 years.
Prevent maternal mortality and morbidity and young age mothers. So to postpone pregnancy and prevent the maternal mortality. So that proposal by Prime Minister is also there.
So thank you all. I now request our honorary secretary of IIM Nagpur, Dr. Rajesh Savarbande, who is an orthopedic surgeon and a very dynamic person, a good friend of all of us.
Lucky he is orthopedician. If something happens, all the broken bones he will be attaching.
So we had
Dr. Rajesh.
Unmute Rajesh.
Thank you, sir. So on behalf of IIM Nagpur branch, I would first like to thank Dr. Manjusha Giri madam for being here with us as a observer from MMC. I also like to thank Dr. Jailal sir and Lele sir, who were consented to be here with us, but because of some previous programs delay, they are not here as a participant. I would like to thank faculty of today's webinar, Honorary Secretary of ESCPI, Dr. Padmashri Prasad ma'am, a consultant gynecologist and sexologist and a marriage counselor, Dr. D. Narayana Reddy, President of AOFS, Chairman of Emeritus and ESEPI, Dr. G. Venkatramana, Chairman of Indian Anthropo Society, and Dr. Kush Jhanjunwala, immediate past president of IIM Nagpur branch and a prominent pediatric consultant here in Nagpur, and our Dr. Sanjay Deshpande sir, who is here as a panelist as well as a moderator and a practicing sexologist in Nagpur. I would extend my generous thanks to Dr. M. Balasubramaniam, a chairman of IIMA National Committee of Initiative for Sexual Health, and his team for association with IIMA Nagpur branch. I'm also thankful to all the participants, and thanks to Chirag and DigiShield team for their technical support. Thank you once again. Thanks to all.